Got axes, baby! Yeah! Well, actually, not axes like guitar axes. No. We're talking axis. Axis! Like ECG axis. That's what this is all about. We're going to start a new section now on the ECG axis. Yep, this is Dr. Nick. Welcome to the intermediate section in the Ecg Academy's interpretation course to make you an ECG expert. It's easy. Just watch all the videos and let me show you how. So this introductory video is more of a review to help you understand how to figure out the axis of an ECG. We're going to be concentrating mostly on 12 lead tracings now. An axis becomes an important point to make certain diagnoses based on whether there's axis deviation. So let's get started. Remember, the ECG is basically a recording system to pick up differences in electrical activity between 2 points in space. Well, that would be a bipolar recording system, and the ECG machine is basically a voltmeter. Now, true, some leads are more unipolar, the augmented leads, and we'll talk more about that. But remember, what a bipolar recording system does is it detects differences in electrical potential or voltage across 2 different points in space. So let's say you have this cloud of electrical activity, these electrical charges. In the body, of course, the cardiac cells depolarize through their action potential. The cells become more positive on the inside, and this movement of sodium and potassium ions creates this electrical signal. So as the electrical signal moves towards this recording bipole, or basically 2 poles of an electrical recording system, they'll encounter the first electrode, and so now there's a difference in electrical potential between the two. So the machine records a positive deflection. As the signals move across, you might wind up with neutralization of this signal. So now both electrodes are at the same voltage, and the signal drops back down to normal. But as this electrical signal moves further, the signal has a potential for becoming negative before this signal finally goes on by and results in resolution of this electrical squiggle. Okay, so this was covered in the electrical theory and the circuits way back in the beginning of the course, but that's generally how ECG machines operate. So let's get to the real heart of the matter. Ha ha ha. Get it? Heart of the matter. The ECG machines record electrical signals from the limb leads and the precordial leads, which are the ones that we put on the chest wall. We'll cover these in a minute. Now, as far as the color coding is concerned, I had reminded you that if you're driving in the United States and your left arm is hanging out the window, it'll get tanned. So that reminds you that the left arm gets the black electrode. The right arm will not be tanned, and so that gets white. Your right leg is over the gas pedal, so you get green for go, and the left leg would be over the brake pedal, and red would be for stop. Now let's keep in mind that in Europe, the color coding is a bit different. And these are the colors in Europe. The right arm gets red, the left arm gets yellow, the left leg is green, and the right leg gets black. Well, for the time being, let's just stick with the US colors and talk about the different leads and what electrical vector they are pointing to. Lead 1 records electrical differences between the right arm and the left arm. Lead 2 records electrical differences between the right arm and the left leg, and lead 3 records electrical differences between the left arm and the left leg, creating a kind of a triangle which is known as Einthoven's triangle after the fellow who did much of the early work in electrocardiography. The right leg is generally used as a ground just to help eliminate some of the electromagnetic interference that these recording systems can pick up from the outside world. Well, we generally don't think about triangles when we talk about axis. We think of a circle. You'll just have to remember the angles that we talked about. Now, the circle is divided up into 360 degrees, with 0 degrees being defined as this point on the right-hand edge. Lead 1, of course, is pointing toward the 0-degree angle. If the axis is located in this direction, the degrees are expressed as positive degrees. And if the axis points in this direction, then by convention we use negative degrees. Now, if we think of this triangle as covering the entire 360 degrees, we can split this up into 6 equal portions. And we have to do that by drawing lines that are 60 degrees away from the horizontal. So remember, in English at least, we read from left to right and from top down. So lead 2 will go in this direction, 60 degrees above the horizontal, while lead 3 will be at this angle, again 60 degrees above the horizontal, thus dividing this circle into 6 equal portions of 60 degrees each. Well, the machine also has 3 augmented limb leads, AVR, AVL, and AVF. And basically what happens in AVL, the left arm is taken as one part of the recording system, and the other pole comes from the other leads, basically summed together. So it's almost sort of kind of unipolar signal, but it's basically looking at signals running towards the left arm. And by convention, we consider AVL to be 30 degrees above the horizontal in this direction. Likewise, AVR is 30 degrees above the horizontal, but pointing towards the right arm. And finally, AVF is basically pointing towards the feet. Well, I had to just fix my lead to a little bit to make it look prettier. But that's basically the whole circle. Now, what does axis tell us? It basically tells us what general direction is the electrical signal traveling. So here's the heart inside the guy's chest. And if the electrical signal is traveling in the proper direction, generally what happens is ventricular activation is going to be traveling down and towards the patient's left. As a matter of fact, the atrial signal starts in the high right atrium, and that will generally travel down and towards the left as well. So we usually consider this quadrant here to be the normal area for axis to be in. If the axis winds up being outside of this quadrant, well, there's a little bit of a margin of error. So if it's in this region here, we'll often call it a leftward axis, but it's not a true left axis deviation unless it's greater than minus 30 degrees. This would be minus 30. On the other hand, if the axis is greater than plus 90, we'll call it a rightward axis until it reaches about plus 120, at which point it really does become a right axis deviation. So you have left axis deviation, which is minus 30 degrees or above, and you have right axis deviation, which is plus 120 degrees or higher. Now, how we actually measure axis using the 12-lead ECG is the subject of the next lesson. But before we get to that, I want to mention the precordial leads, because indeed there is a kind of an axis in the precordial leads. Just imagine this yellow oval as being the chest wall with the spine in the back and the sternum in the front. Remember that the heart is attached to the mediastinum at the base, and you've got the pulmonary veins leading into the left atrium, and you've also got the inferior and superior vena cava feeding into the right atrium. The ventricles are clearly lying to the left of the spine in most patients, but because the heart is twisted up, the right ventricle is generally anterior towards the front of the chest, and the left ventricle is more posterior towards the back of the chest. So as the depolarization travels down the septum and towards the apex in two directions, you basically have electrical signals that are traveling towards the side of the heart. Now here are the precordial leads and where they're positioned on the chest wall. So if you recall from my earlier talk in the basic section, V1 is recording electrical signals from the front, and most of the signals are going away from V1. And so what you'll usually measure in V1 is sometimes a small R wave, which represents the septal depolarization. If you recall from my basic section, if you don't recall that, you can review that video. But you'll have a little septal R wave and then mostly a deep S wave because the signals are traveling towards the side away from V1. On the other hand, V6, since the septal activation is traveling away from V6, what you usually have is a small Q wave, which is known as the septal Q, but then most of the signal is traveling towards V6, so most of the QRS complex is positive in V6. Somewhere between V3 and V4 is known as the transition point. The transition point is when the R wave grows larger than the S wave, and generally there's a gradual transition across here with V2 having a slightly bigger R wave. V3 sometimes is the transition point, so the R equals S, and sometimes it's V4 where the R becomes taller than the S wave. In V5, there's usually a residual S wave, but by V6, there should be very little S wave left. So you have this gradual R wave transition across the precordium, and we'll talk about abnormalities in this R wave progression in the third lesson in this section. Well, now that we've discussed where the axis comes from, in the next video, we're going to talk about calculating the frontal axis. That's the axis determined by the limb leads, and I'll give you a couple of different ways of doing that. But for now, this is Dr. Nick for the Ecg Academy. Thanks for watching. Hey, this is Dr. Nick with the Ecg Academy, and we're continuing our discussion on Ecg axis. This lesson is designed to help you figure out exactly what the axis is, and I'm going to show you a couple of different ways where you can determine the axis. First, let's recall where these leads are talking about. So lead 1 goes from right arm to left arm and is basically a horizontal vector that goes right across the middle of the circle. So that's lead 1. AVF, on the other hand, is an augmented lead that looks at the left leg compared with the sum of the other leads. And so it's really more of a vertical vector pointing towards the feet. So that's where AVF comes from. Now remember, the vector is a mathematical derivation. And I know a lot of you guys hate math, but we're really going to have to touch on this a little bit. In the normal heart, the QRS vector will go down and to the patient's left. And if you remember from our bipolar recording system discussion, anything that goes sort of in line with a bipolar recording system will register a positive deflection, and anything that's going perpendicular to a bipolar recording system winds up being much smaller since the electrical signal is reaching both poles at the same time. If you don't remember this principle, you can go back to my video talking about electrical recording systems. Well, since the normal vector has to be moving towards the left and also down and towards the feet, we expect that in lead 1, the QRS will be positive, and in lead AVF, the QRS will be positive, meaning that the average electrical direction or vector is going somewhere in this direction, and in fact, this would be the normal quadrant where the axis would be located. But exactly how do we figure that out? How do we calculate in degrees what the axis happens to be? Because it becomes important in making certain diagnoses. So let's go over a couple of different ways to do that. Well, here's a normal QRS, and of course, frontal axis is derived from the 6 limb leads. So here's lead 1, and it certainly seems to be positive. And here's lead AVF, and that seems to be positive. And so the quick and dirty method would say, well, since lead 1 and AVF are both positive, that must mean that you are in the correct quadrant, and so this is a normal axis. Well, that's true, but really inadequate. If you want to become an ECG expert, you really have to be able to tell exactly what the axis is in degrees. So how do we figure that out? Well, I'm going to show you the mathematical way first, but trust me, no one does this on a day-to-day basis, but I want you to understand the mathematics behind it. So instead of a circle, what I've drawn here is a grid with kind of an x-axis and a y-axis. And you probably thought that since you passed your algebra course, you were done with this, but indeed, Dr. Nick has to bring it up again. Nice. Well, anyway, this was lead 1 in that other ECG tracing. And yes, it was positive, but how positive? See, in order to be able to measure the axis exactly, and this is how the computer will do it, what you first need to do is find the baseline. So I've drawn a red line across here from baseline to baseline. What's really important is how far above and below the baseline the QRS complex goes. And so it's a matter of counting small boxes above and below and take the sum. That means add the positive and the negative. So you have 1, 2, 3 small boxes above, that's plus 3, and then you have a half a small box below, so that's 0.5. So the net is plus 2.5. Now let's say we plot that on the x-axis since lead 1 is pointing in this direction. So let's plot 1, 2.5. Okay, so that's where we're going to wind up creating a point in space that would be designated 2.5 as the x coordinate, and now we're going to figure out what the y coordinate is. And I know you're thinking, oh my God, I can't wait till this is over. Okay, well, here's the tracing for AVF. Now, if I throw a red line across the baseline, now let's measure how many boxes above and below the baseline this QRS happens to be. So we'll do below first because that's a little bit easier. 1, 2, 3, 4. So we have minus 4 boxes below. And now let's count above. We'll take it by 5s. This would be 5, 10, 11, 12, 13, about 13 and a half. So 13.5 minus 4 gives you a net of plus 9.5. Since AVF is positive, we have to keep in mind that that's headed in this direction. Okay, don't be confused with the positive and negative x and y. We have to go down 9.5, which would place us right at this point, because this would be 9.5 headed towards the feet. So the vector, in fact, is the line that goes right through this point. Okay, so what's the axis? Well, we have to find out what this angle is, because this is the angle designated by this vector. Now, if you remember trigonometry, the tangent of an angle is equal to the opposite over the adjacent. So from this angle, the opposite is this length, which is 9.5, and the adjacent is this one, which is 2.5. Bear with me, it's almost over. So to figure out what this angle is, we take the arctangent of 9.5 divided by 2.5, and that gives us, if you plug it into your fancy calculator, and in round numbers, that equals 75 degrees. Okay, well, now that that's over, let's find an easier way to do it. Okay, keeping in mind that any time an electrical signal goes perpendicular to the bipole, if it's traveling in this direction, it's not going to give you much of a deflection. what you need to do is find the one lead that's most isoelectric. That means find the one that's equally above and below the baseline, so that if you subtract the negative from the positive, that you get as close to zero as possible. I mean, it's much easier to see than it is to say, because if you look at all these leads, this is clearly positive, this is very positive, this is way positive, this is way negative, this is positive. So AVL really has a QRS complex that's almost equal above and below the baseline. That's what we mean by isoelectric. In this case, isoelectric means that there's equal deflection above and below the baseline. So if AVL is most isoelectric, where does that point to? Well, if you recall, here's lead 1, and AVL points 30 degrees above the horizontal. Okay, so this is 30 degrees because it points towards the left arm. So the perpendicular of that has to be here, which would be 90 degrees from that, and that means that this angle has to be 60 degrees. That's what the axis is, plus 60 degrees. Now remember, lead 1 is positive, and AVF is positive. You're in that normal quadrant, and it's fine. But if you take a closer look, you can see that AVF is much more positive than lead 1 is more positive. So it's going closer to AVF. It's pointing more towards the feet than it is pointing towards the left arm. That's why the vector is closer to plus 90 than it is to 0 degrees. Now keep in mind that because AVL was isoelectric, it's possible that the vector was also going in this direction, because that would also be at a 90-degree angle to AVL. But if that was the case, it would be going away from the inferior leads 2, 3, and AVF. And so 2, 3, and AVF would be negative. So that's a way to check yourself. Find the most isoelectric, and then if the inferior leads are positive, then you know it's in the bottom half of the circle, and you take the perpendicular in the bottom half to get your axis. Now let's try another example. At first glance, you see the QRS complex is up in 1, but it's down in AVF. And so it's going away from the feet. We have an axis now that it's got to be in the top half of the circle. Since it's going towards lead 1 and it's going away from AVF, that tells us roughly that it's got to be in this quadrant someplace. So what we need to do next is just figure out which lead is most isoelectric. Well, I use this tracing because it's a little bit more challenging. Because if you look at lead 2, it looks kind of isoelectric, although it's a little bit more negative than it is positive. But if you look at AVR, it's also almost isoelectric. It's also a little bit more negative than it is positive. And so there's not one single lead that's isoelectric in this tracing. And what you have to do here is take the vector that's in between the perpendicular of these two leads, because the axis really lies in between the two of them. Okay, let's start with lead 2. So lead 2, since English is read from top down and left to right, lead 2 is in this direction, 60 degrees above the horizontal. And so if lead 2 were isoelectric, the axis would be minus 30, because that would be the perpendicular to this, and it would be 30 degrees above the horizontal, since this is 60 degrees below. Well, what about AVR? Remember, AVR points towards the right arm, and that's 30 degrees above the horizontal. So if AVR was the most isoelectric lead, that would give you a vector of minus 60. And so the vector in this case has to be in between those two, and that gives us minus 45. That kind of makes sense because the size of lead 1 is equal to the size of AVF. And so it's going towards lead 1 as much as it is going away from AVF. In other words, if we were to plot this on one of those grids, one of those X and Y grids, I know you hate that, but lead 1 would give us the same distance on the X-axis as lead AVF would give us going away from the feet. And because these two sides of this triangle are equal, that gives us a 45-degree angle. In the next lesson, we're going to practice determining ECG axis, and we'll talk about the different conditions that can lead to axis deviation. Until then, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey, this is Dr. Nick, and we're going to continue this third lesson in the section on QRS axis. Now we're going to deal with axis deviation. And I've put this shopping list of causes of left axis deviation. You can have left and you can have right axis deviation. Well, what does that amount to? Well, think of the heart again, and you have fairly thin right ventricular free wall. You have your septum, which is pretty thick, and your left ventricle, which is thick as well. Of course, your atria are up here someplace. So what normally happens is the electrical vector winds up going down and to the left. But now there are a number of different things that can shift this axis upwards, and that would give you a left axis deviation. Anything that causes this part of the ventricle to enlarge and become heavier, or anything that shifts the sequence of activation of the left ventricle around, disturbing the normal sequence of activation can result in shifting of the axis upwards and towards the left. We'll talk specifically about how this happens in our discussion of hemiblocks later on in the intermediate course. But for now, let's just discuss the more common causes of left axis deviation. It can occur as a normal variation, and usually what we're talking about is an axis, in the range of minus 20, more of a leftward axis is usually normal, but it could possibly reach minus 30 as a normal variation. Left ventricular hypertrophy is a very common cause of left axis deviation because you have all of this left ventricular free wall activity, and it winds up causing the electrical vector to shift towards the left ventricle, which basically this disturbs the normal relationship between the right ventricle, which is thin, and the left ventricle, which is thicker. A left bundle branch block is another common cause of left axis deviation, although not always. Anterior fascicular blocks will be discussed in detail later in this intermediate course. Now, just a word about inferior myocardial infarction. Remember, the inferior wall is the underside of the heart, and if you wind up with an infarction in that part of the heart, then there's a relative absence of electrical signals that are headed towards the bottom part, and so the net electrical vector winds up shifting upwards and towards the left. So left axis deviation is commonly seen in inferior myocardial infarctions, and when we discuss how to diagnose myocardial infarctions later in this intermediate course, we'll relate that axis deviation to it as well. Usually in lead 2, you would expect to see a fairly healthy R wave, but in an inferior wall MI, those forces headed towards lead 2 are conspicuously absent, and in fact you wind up with Q wave and a shift in the axis with most of the electrical signal being below the baseline. And that tells you that the electrical signal is headed away from lead 2 up in this direction. Congenital heart disease can disturb the normal architecture of the left ventricle, and other less common causes of left axis deviation include emphysema, hyperkalemia, and preexcitation, otherwise known as the WPW syndrome. We touched on this briefly in the basic course, but the advanced course will cover this in much more detail. Of course, if the diaphragm is pushed upwards for some reason, like by a large uterus or fluid in the abdominal cavity, such as you'll get with ascites, or if there's a big tumor in the abdomen that pushes the diaphragm up, well, that will physically shift the heart to lie more horizontally and then winds up with your axis shifting leftward. So that's more of just a mechanical shift rather than it being an electrical or a structural shift. Okay, what about right axis deviation? Well, sometimes hearts can be relatively vertical in the chest, and that can wind up shifting the axis a little bit sort of rightward. So normal variation is one cause of a rightward axis. Mechanical shifts as well. If the right ventricle becomes thickened for a variety of reasons, then you have more electrical signal being generated by the right side of the heart, and the electrical vector will shift towards the right. Right bundle branch block and posterior hemiblock are electrical disturbances that can cause a shift in the axis. Dextrocardia is a condition when you're born with the heart on the right side of your chest. It's a congenital abnormality, and because the heart is now lying this way, the axis, of course, is going to be very bizarre, as will the rest of your ECG. Preexcitation syndrome, or WPW, can cause marked shift in axis. Just like an inferior wall myocardial infarction can shift the axis leftward, if you have a lateral infarction where this part of your heart is damaged, then the electrical vector shifts from this direction to this direction. So you get a right axis deviation with a lateral wall MI. Anything that causes right ventricular enlargement, either acutely or chronically, can shift the axis to the right. So pulmonary embolism causes acute increased right ventricular size and wall tension, and a chronic condition that occurs in patients with lung disease is known as cor pulmonale, and that causes right ventricular enlargement and hypertrophy, often seen with pulmonary hypertension. Okay, well, let's start getting some practice here. We'll concentrate on the frontal leads again. And the first thing you should do is look for the one frontal lead that seems to be most isoelectric. This seems to be more positive. This seems to be more negative. This is positive. This is pretty close to being isoelectric. It's certainly the smallest lead, but if you carefully examine the baseline, you see that most of the QRS complex is below the baseline, about 2 millimeters below, and there's only about 1/2 of a millimeter above it. So this is clearly more negative, although not by much. Lead 2, on the other hand, shows about 3 millimeters above and below. So even though lead 2 is larger than AVF, it seems to be most isoelectric. Now, where is lead 2? Lead 2 is going down 60 degrees from the horizontal. And if lead 2 is most isoelectric, that means the electrical signal is traveling perpendicular to that, which would make it minus 30 degrees, bordering on left axis deviation. And generally what I look for is if all 3 inferior leads are negative, then I call left axis deviation. Notice, however, that AVR is still negative. Where is AVR located? Well, AVR is 30 degrees above the horizontal going in this other direction. And for the most part, the QRS complex should always be negative in AVR unless the axis is minus 60 degrees or better. If you see a positive QRS complex in AVR, then you're clearly dealing with axis deviation. I'll show you a few more examples of this. AVR is obviously very positive here, and 2, 3, and AVF are markedly negative. Lead 1 is the only lead that seems to be fairly normal. So where do we put this axis? So here's lead 1, and since this is positive, we know that it's got to be in this half of the circle. It turns out that lead 1 is probably the most isoelectric. All the other leads are very large. And even though it's more positive than negative, we have to call this axis very close to being minus 90. Now, it's not exactly minus 90, but there's no other lead that's as isoelectric as lead 1. If AVR was isoelectric, it would be minus 60. And so it's clearly more than minus 75 if you wanted to be precise. And if you did it the mathematical way, I think you'd find it to be probably minus 80 or 85 degrees. I think this would be the closest guesstimate given the configuration of the QRS complex here. What would make an axis deviation that abnormal? Well, this is an example of left anterior fascicular block or left anterior hemiblock, which is characterized by having a little R and a deep S in lead 3 and a small Q with a taller R in lead 1, as well as an axis of minus 60 degrees or better. But we'll talk about anterior hemiblocks and why it looks this way later in this course. Just I want you to get comfortable with determining the QRS axis. In this case, it's about minus 80 degrees. All right, here's another example. It's a little bit easier. AVR is clearly negative, so it's not going to be quite as bizarre. But you see lead 1 is positive, but AVF is negative, so it's not in the normal quadrant. As 2, 3, and AVF are negative, that places it in the top half of the circle, and lead 1 being positive puts it into this quadrant. Well, which lead is most isoelectric? It looks to be lead 2. That has about 10 millimeters below and maybe 6 above, which is more isoelectric than AVR. It's not perfect, though. So for the ECG experts in the crowd, lead 2 is 60 degrees above the horizontal, and if it were isoelectric, that would give us an axis of minus 30, but it's a little more negative than that. And remember, I told you if 2, 3, and AVF are all negative, then you're clearly dealing with a left axis deviation. But AVR is not as isoelectric as lead 2, so it's not as far as minus 45, and I'd call it minus 40, and I think if you read it on the computer printout, that's about what the computer would calculate mathematically. Now, why does this patient have a left axis deviation? Well, look at the size of the R wave in lead AVL. If you measure it, it's almost 20 millimeters. And if the R wave in AVL is greater than 11 millimeters, well, that's one of the criteria to diagnose left ventricular hypertrophy. You have several other criteria here that you meet. Huge S waves in 2 plus a big R wave in 1, that's one criteria. And then in the precordial leads, you also have voltage criteria as well as ST segment abnormalities consistent with LVH. So that's why you have a left axis deviation of minus 40 degrees. In this tracing, it's because of left ventricular hypertrophy. Okay, last one just for practice. Now here, if we kind of look at 1 in AVF, we see AVF is positive, but lead 1 looks to be negative. Well, that would place our axis on this side of the circle, wouldn't it? Because we're going away from lead 1. Lead 2 seems to be most isoelectric. Remember that lead 2 is going in this direction, 60 degrees above the horizontal. So the axis in this tracing looks to be over here, a marked right axis deviation. It's 90 plus another 60. That gives us plus 150 degrees. Now here again, AVR is positive, and that tells us that we're here, the abnormal side of the circle, because what you have here is left posterior fascicular block or left posterior hemiblock in combination with a right bundle branch block with notching in V1 and V2 and a wide deep S wave in the lateral leads here. So you've got right bundle branch block, left posterior hemiblock, giving you this marked right axis deviation of plus 150 degrees. As we work our way through all these ECGs in the intermediate course, I'm going to keep pounding home these points about determining axis and using axis deviation to help you make diagnoses. In the last video of this section, I'm going to touch on the precordial leads and how precordial lead progression can become abnormal and it can help us make diagnoses as well. I'll also introduce the idea of anatomical correlates to different ECG leads so we can nail down the anatomical regions that we refer to, such as the lateral leads and the anteroseptal leads and the inferior leads as we go on and start talking about ST segment abnormalities and other regional myocardial problems. So for the Ecg Academy, this is Dr. Nick. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this last video on this section on axis has to do a little bit with precordial leads, and then we're going to discuss the anatomical correlations to the different leads that we see on the 12 lead. Now, when we mention inferior leads and lateral leads, I just want to make sure you guys are clear with that. So without further ado, let's talk about the chest leads, the precordial leads. This was my diagram of someone's chest with the spinal column in the back and the sternum in the front. And this is how I introduced the idea that the heart is in the chest with the left ventricle pointing more posterior and the right ventricle being more of an anterior structure. But you see, radiologists, when they read CAT scans and so forth, they actually look at the body from below. So if I were to simply flip this over, it would look a little bit more like what a radiologist sees when he reads a CAT scan. It's just a different angle looking from below. And if we put our precordial leads in here with V1 being on the right side of the sternum, V2 on the left, and so forth, until you get to your mid-axillary line, you can see it's the same idea except just upside down. Now, if I put the normal precordial progression, with V1 having perhaps a little R wave and a very deep S wave, V2 having somewhat of a larger R wave, the transition point where the R becomes bigger than the S is usually somewhere between V3 and V4. And then V5 is usually a tall R with a little S left, and then V6 is usually not much of an S at all. So this is a normal precordial progression, or sometimes we call it the R wave progression because it's really the R waves that are getting bigger and bigger as we go across the precordium. Well, just like you can have frontal axis shifts, you can also have a shift in the precordial progression. And in a simplistic way of looking at it, it's almost like the heart can be rotated in the chest. Okay, so imagine if the heart inside the chest could rotate, either because of anatomical changes or because of functional changes. If the heart is able to rotate in a clockwise direction, what will happen is that the transition point, instead of V3 or V4, may wind up being V5 or V6. So clockwise rotation of the heart inside the chest winds up giving you late transition. So clockwise rotation of the heart winds up giving you late transition. Late transition occurs when the R wave doesn't grow until V5 or V6. So you have persistent small R waves all the way out until maybe V5, and then V6, perhaps the R wave finally grows bigger than the S wave, but there's still a pretty sizable S wave in V6, and we call that late transition. Conversely, if the heart becomes rotated in the opposite direction, counterclockwise rotation winds up causing the ECG to show an early transition. So with counterclockwise rotation, you wind up with early transition. And this looks like you may have a sort of a tall R wave in V1, but then you have an R wave that's bigger than the S wave in V2. And this R wave remains large for the rest of the precordium. And so this is known as early transition, or counterclockwise rotation. These are often variants of normal, but it's often seen in people with conduction system disease like left anterior and left posterior hemiblocks. So here's an example of late transition. When you look at the QRS complexes, they look fairly narrow. So interventricular conduction is normal. The QRS is isoelectric in lead 3, so that gives you an axis of plus 30. But let's examine the precordial leads. You have a little tiny R wave here, and it remains small. It's still small, but look how deep the S wave is. You have this persistent deep S wave all the way out to V5. The R wave still hasn't grown much. And then finally V6, the R wave begins to grow, but you still have this big S wave here. So the precordial transition point is at V6, and we call this late transition. We might be tempted to interpret this poor R wave progression as being evidence of an old anterior MI, but we'll talk about this in a later section. This late transition is more of an electrical phenomenon and not necessarily related to any anatomical problems. Now, with this ECG is a little bit more confusing. It's the best example I have of early transition. Now, the rhythm is sinus, but there happen to be PACs that are aberrantly conducted. You can see a deep S wave here, and in V1, there is a P wave that's hidden on the T, and there's an RSR prime, so this is basically just a PAC that conducts with a right bundle branch block. But look at the underlying QRS complexes right here. You can see that the R is not as tall as the S wave in V1, but in V2, the R wave is much taller than the S wave, and the R remains tall for the rest of the precordium. So this is an example of early transition, and it can be seen in conduction system disease, as well as some anatomical abnormalities. And these are things that we'll cover in later sections, but RVH would look different because it will generally have a deep S wave in V6, and an old posterior MI would usually have a taller R wave in V1. So the equivalent of axis deviation in the precordial leads is either late or early transition. I promised that I would talk about anatomical regions of the heart and how the different leads relate to those anatomical regions, and let's do that now. Recall that the frontal leads, we have 1 and we have AVL, are all angled in this region. If we look at the precordial leads, with the sternum in the front, we have V1, V2, all the way to V5 and V6. So V5 and V6 are looking at the side of the heart, as is AVL and V1. So the lateral leads are considered to be 1, AVL, V5, and V6. Okay, so these are lateral leads. They look at the lateral wall of the left ventricle, and you have to kind of keep those in mind when you're trying to diagnose a segmental myocardial problem like ischemia or infarction. Now we have AVF, which is pointing straight down. We have 2 and we have 3. So 2, 3, and AVF are considered the leads that are best suited to examine what's going on with the inferior wall of the heart. Lastly, if you think about the heart in the chest, V1 and V2 are often looking at the right ventricle, and V2 and V3 are often looking at the septum. So we consider these to be RV leads and septal leads. And then V3 and V4 are looking at the anterior wall of the heart. So V3 is anterior, V4 is anterior. If you see changes that involve V2 through V6, then we call it anterolateral. If it's V1 through V4, it's anteroseptal. Let's kind of review the anatomy of the heart here. This is a front view of the heart with the right ventricle over here and the left ventricle on this side. Coronary arteries include the left anterior descending, which basically runs through the interventricular groove and gives off branches to the lateral wall. These are known as diagonal branches. So when you see coronary problems with the left anterior descending, usually affects the septum, the anterior wall, the lateral wall, and the apex. On the other hand, the right coronary artery, which runs in the right AV groove and then gives rise to branches that supply the right ventricle, wraps around the heart and feeds the posterior wall and the inferior wall. So inferior left ventricular problems and right ventricular problems are usually due to right coronary artery blockages. The circumflex coronary artery comes off the left main, and that runs in the left AV groove, giving off marginal branches. These are obtuse marginal branches to the lateral wall of the left ventricle, and in some patients, it wraps around in the back of the heart and supplies the inferior wall. So inferolateral changes can sometimes be a reflection of the circumflex. Now I'm going to cover the coronary artery anatomy in much greater detail in the advanced course, but for now, just think about septal and anterior changes changes almost always being due to the LAD or left anterior descending coronary. Lateral changes could be either LAD or circumflex. That's 1 AVL, V5, and V6. Inferior wall changes are usually due to right coronary artery problems, although in some patients the inferior wall is supplied by the circumflex. And so inferolateral changes can sometimes be a reflection of circumflex disease. So this is just an introduction to the concept that anatomical problems involving certain coronary arteries can be reflected in certain patterns of change in the ECG, and that sometimes correct interpretation of the ECG can point to which coronary is involved. So as we continue this discussion in the intermediate course, we'll continually refer to anteroseptal leads and lateral leads and inferior leads until you get comfortable with the concept that the ECG does reflect anatomical areas of the heart. Well, that concludes my discussion of the axis and the end of this section. In the next section, we'll discuss atrial abnormalities, which are a bit easier to diagnose and less complicated than this kind of stuff. But until then, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and we're starting a new section on P waves, talking about P wave axis and P wave abnormalities, otherwise known as atrial abnormalities. This belongs in the intermediate section. For you subscribers who want to be an ECG expert, let's start talking a little bit more about the P wave. Now, as you recall, the sinus node is up in the high right atrium, near where the superior vena cava comes and plugs in. And so normal P waves generally spread out from that point. Now, if you recall, there's also a bundle that runs behind the great vessels. It runs in the back of the heart and connects the right atrium with the left atrium. And this is known as Bachmann's bundle. And so Bachmann's bundle is the route over which atrial signals travel from the right to the left. So we talked about how the P wave represents the electrical activity of the atria, but it really is sort of a sum of all the atrial signals that arise from both the right and the left atrium. Now, normally the atrial axis, which we can calculate from a 12 lead, should be traveling down and to the left. So if we get our axis here, if this is lead 1 and this is lead AVF, normally the atrial axis should be down in this direction around plus 45 degrees or so. And just like a QRS complex, we can calculate the P wave axis looking at the 12 lead. So let's look at a typical fairly normal ECG. So we have P waves in front of every QRS complex, and they're upright in lead 1 and they're upright in lead AVF. When you determine the axis, you're going to find that it is indeed in the normal quadrant. But let's be more precise. Let's come up with a degree of angle. So the easiest way is to look for the most isoelectric P wave in the frontal leads. So this is clearly upright, and is this one. AVR is clearly inverted, and so AVL looks like is the most isoelectric. That is, it's not just the smallest, but it's fairly equal above and below the baseline. So the limb leads are 30 degrees above the horizontal, and AVL is pointing towards the left arm. So this axis would be perpendicular to that, and that would give you plus 60. It's just like calculating the QRS axis, except the P waves are sometimes a little harder to see. But with a little practice, you'll find it's not that hard. Here's, for practice, here again we have a sinus rhythm with P waves that are up in 1, and they're up in AVF. So we know it's in the normal quadrant, but now where's the most isoelectric? We can see it's clearly up in AVL, and we could look at lead 3 is just slightly positive, but so is AVF just slightly positive. All the other P waves are much larger. So remember, if you don't have one lead that's perfectly isoelectric, you have to find the two leads that are most isoelectric and then calculate the axis based on those two. So these two are kind of equally just slightly positive. So if AVF was isoelectric, then that would give us an axis of 0 degrees. Let's draw in the other inferior leads. Remember, in English, we read from left to right and top down, so lead 2 is 60 degrees above the horizontal and goes in this direction, and lead 3 would go in the opposite direction, again 60 degrees above the horizontal, splitting the circle into 6 equal parts. So what angle would be isoelectric to lead 3? Well, if this is 60 degrees, then the perpendicular of that would be plus 30. Now we're saying that the axis is in between the isoelectric for lead 3 and the isoelectric for lead AVF. And so the answer here is about plus 15 degrees. Okay? See, it's not so hard. You just have to practice. Now, we'll talk about atrial abnormalities. And in fact, an axis of less than 30 degrees suggests a left atrial abnormality. But I'll be covering all the criteria for atrial abnormalities in the next video. Okay, we'll take one last one for practice. Now, this is a little bit faster. Without spending too much time, you can see that two QRSs are exactly 1 second apart. That's 300, 150, 100, 75, 60. So since the rate is double that, we have a rate of 120 beats per minute. The P waves, you can see they're clearly inverted in the inferior leads. So this P wave is headed towards the head. In fact, it's positive in AVR, which is very abnormal. It happens to be slightly positive in AVL. And it appears to me to be slightly negative in lead 1. But lead 1 is probably the most isoelectric. Well, if it's going away from the feet and it's perpendicular to lead 1, that tells you that the axis is up here someplace, which makes sense since AVR and AVL are both positive, and those are both headed towards the head. So it has to be in this part of the circle. Now, if lead 1 was perfectly isoelectric, I would call this axis minus 90. But I'm going to be nitpicky and say that since lead 1 is a little bit negative, that means it's going away from lead 1 a little bit. And so if your head is a computer, it's probably going to wind up about minus 100 degrees. It's not quite 105, because if it was 105, then that would be isoelectric to lead AVL, but clearly it's going up in AVL. So you might even split hairs and call it minus 95, but it's in there someplace, just to the left of straight up. Well, this is pretty typical for either an ectopic atrial rhythm, where the P wave is arising from someplace down in the low right atrium, let's say, or the low left atrium, and going towards the head. But in fact, this happens to be a particular kind of supraventricular tachycardia where the P waves are retrograde. They're arising from the region of the AV node, and they're traveling towards the head in both directions. So these are actually retrograde P waves, and generally they have an axis that is very superior up here someplace. One last ECG to practice looking at P wave axis. And as you look across this 12 lead, you can see it looks fairly regular, but what should jump out at you is the fact that the P waves seem to be inverted in 2-3 and AVF. Now, the PR interval is somewhat short. It's about 120, maybe 140 milliseconds, and it would not be correct to call this a junctional rhythm, but rather this is an ectopic atrial rhythm. An ectopic atrial rhythm arises from someplace other than the sinus node and is associated with an abnormal P wave axis. There's another term some people use as a coronary sinus rhythm. And a coronary sinus rhythm describes an atrial rhythm that arises from somewhere in the low left atrium. Because if you remember, the coronary sinus runs behind the left atrium in the left AV groove and empties into the right atrium. It's the main vein that drains the heart. So this is on the back wall of the left atrium. And if there's an ectopic focus there that starts to fire, you're going to have a P wave that's clearly pointing towards the head, a superior going P wave with inverted P's in 2-3 and AVF. So the old-fashioned term would be a coronary sinus rhythm. But I think ectopic atrial rhythm is a more generic term, and I think that would be the one you should use. Of course, if the heart rate is greater than 100, we'd call it ectopic atrial tachycardia, and then you'd have to start thinking about whether it might actually be some kind of SVT like the last ECG showed. Anyway, let's look at the axis. If we look at all the P waves, scan around, you see that lead 1 is again isoelectric. So just like the tracing before, if lead 1 is isoelectric, that means the signal is going away from the feet perpendicular to lead 1, and that makes the axis minus 90 degrees. So you can see it's pretty easy to figure out what the atrial axis is, and that helps you make the diagnosis of the underlying rhythm. In the next video, we're going to start talking about left atrial abnormality. And it turns out that one of the criteria for left atrial abnormality is an axis of less than plus 30 degrees. And you'll find out why when you watch the next lesson. In the meantime, this is Dr. Nick for the ECG Academy. Thanks for subscribing. Hi, this is Dr. Nick with the Ecg Academy, and we'll continue our atrial discussion now talking about left atrial abnormality. As you recall, the sinus node gives rise to each P wave, and right atrial activation spreads down and to the patient's left. And then what happens is the electrical signal passes through Bachman's bundle and inserts into the high part of the left atrium, and then the left atrial activation spreads down into the patient's left. So in fact, the P wave consists of two different distinct contributions, part of it from the right atrium and part of it from the left atrium, the beginning part from the right, the second part from the left. And what happens with left atrial abnormality is that you begin to see abnormalities in the second part of the P wave. This is due to the fact that the left atrium may be enlarged, it may be distorted, and it takes a lot longer for the electrical signal to get around the left atrium. A left atrial abnormality was once called left atrial enlargement, but it turns out that the criteria that we use are really not that specific or sensitive. And so it's better to consider an abnormality, meaning there's something wrong with the P wave, and accept the fact that it doesn't always necessarily translate to a real disturbance in the left atrial size. Having said that, let's quickly review where the atrial axis should be. Remember that in most patients, the normal P wave winds up being in this quadrant, but the axis should really be between plus 30 and somewhere around plus 90. This is really where the normal P wave should be. Now, how do we diagnose left atrial abnormality? There are a number of criteria, which I'll now cover. So if the left atrium is enlarged, and that second part of the P wave takes longer to inscribe, the total duration of the P wave will be prolonged, given the sum is the signals from the right side and also from the left side. So if the total duration of the P wave is greater than 120 milliseconds, that's consistent with left atrial abnormality. Now, this criteria happens to be very sensitive. So if the left atrium is in fact large, then it's very likely that this criteria will pick it up. But it's not very specific. In other words, just because you see a long P wave doesn't necessarily mean that you have definite enlargement. This is the least specific of all the criteria. The second criteria is a P wave axis of less than 30 degrees. And so that means we're talking about a P wave axis somewhere in this region. That happens because stretching out of the left atrium basically moves the P wave axis leftward. And so you have less of the electrical depolarization traveling towards the feet and more of it is traveling towards the lateral side. Now, because the P wave is made up of two components, the right side and the left side, if the left atrial component gets larger, what happens is you get a second bump. And that's what we refer to as a double bump or a bifid P wave that's most often seen in lead 2. It used to be seen in mitral valve disease like mitral stenosis, and so that double bump is often called P mitrale. Think of it looking like the letter M, and that will help you remember P mitrale. Now, for this to be significant, the two bumps should be separated by at least 40 milliseconds, or one small box. So that takes care of this criteria, and it turns out that is a very specific finding, that if you see this, then left atrial enlargement is almost certainly present. The next criteria is a significant negative P force in V1. So in V1, what you'll see is sometimes two phases, but it's the larger second part of the P wave that actually gives you the diagnosis. Now, why is V1 so important? Well, remember, V1 points towards the anterior side of the chest wall. If you take the chest and you cut it across, with this being the spine and this being the sternum, the left atrium is a posterior structure, with the right atrium being more anterior. And if V1 is here, then left atrial enlargement will increase the number of forces going away from V1. That's why you have this negative deflection. For it to be significant, it should be at least one box wide and at least one box deep. And that is another fairly specific finding for left atrial enlargement. The last criteria for left atrial abnormality is a positive terminal P in AVL, which means you have a lot of P wave electrical activity heading towards the lateral leads, and that should basically be at least a half a millimeter in size. Well, let's take a look at a couple of examples just so you get used to seeing what this looks like. Here's a 12-lead in normal sinus rhythm. The rate here is about 90 beats per minute. The PR interval is at the upper limits of normal. It's about 180 milliseconds. If you're looking for a P wave axis, it's fairly isoelectric in 1. It's markedly positive in 2, 3, and AVF. AVL is a little bit negative, and AVR, I think, is a little bit more negative. So we're talking about P wave axis in this case, since it's nearly isoelectric in 1 and AVL. 1 would give us plus 90. AVL would give us plus 60, so it's somewhere in the plus 75 range. But I wanted you to see this double notching of the P wave in lead 2, and the 2 bumps are clearly separated by more than one small box. You also see a negative deflection here in V1. I'll show you something even more impressive in the next tracing. But you have a small positive deflection, and then you have a large, wide negative deflection that's more than one box wide and just about one box deep. So this would likely be read as left atrial abnormality. In fact, you'd be surprised at how many ECGs are labeled as possible left atrial abnormality. Keep in mind that these criteria do not necessarily mean true left atrial enlargement. That's more accurately diagnosed either by echocardiography or more recently with MRI volume analysis. Okay, we'll get to one more example here, and I think this negative deflection in V1 really sticks out like a sore thumb. This is one of the more impressive examples of left atrial abnormality that I've seen, although there are others, and I'll show you those in the next video. But you have a fairly wide P wave here. It approaches 120 milliseconds. You don't have a double bump here in lead 2. But I want you to see something else that's interesting. When you look at lead 3, there are these negative P waves, and then there's a positive P wave with what looks like a double bump. And now you're going to wonder, well, which am I supposed to look at? Because obviously the axis of these 2 P waves is markedly different. And if you look at this P wave, it looks distinctly different from this one. So which is the real one? Well, here's where you have to kind of use your imagination. And it also helps to have a good pair of calipers. Now let's take these calipers and move them over to the R to R interval right over here. And if you measure, you can see there is a little bit of irregularity here. So there is a predominant R to R interval, okay, and I've shown that to you here with a heart rate of about 82 or 85 beats per minute. But let's see what's happening over here. If you measure back from this R to R, you see that it doesn't quite time out. But if you measure back one more, you see that there's a tail end of an S wave. And you can see that this patient actually has a right bundle branch block with an RSR prime in V1, and there's a wide S wave in lead 1. So what you're seeing here is a wide S wave in lead 1. That this QRS occurs on time. What exactly does that mean? Well, these 2 are on time, and so is this one. And if this QRS was on time, it would have landed here. And so what this is a PAC. A premature atrial contraction. That's why the P wave looks different. And if you look at this beat, it also comes prematurely compared with these, where you would normally expect the QRS to land here. So we have a PAC, a couple of sinus beats, a PAC. You have sinus rhythm for the rest of the tracing. That's why it's a little confusing, because this PAC has a different axis. It's an ectopic beat, and it has a different axis from the rest of the QRS complexes. So if we go ahead and try to calculate the axis of the sinus beats, we see it's negative in lead 3, and it seems to be most isoelectric in AVF. And that would make sense because AVF is here, and if it's isoelectric in AVF, that would make the axis 0 degrees. Lead 3, on the other hand, is headed in this direction, 60 degrees above the horizontal, and so an axis of 0 degrees is going away from lead 3. And that's why the P wave is negative. So it all makes sense. Well, if you want to split hairs, you'd say that AVF is a little bit positive, so that makes the axis more like plus 5 or plus 10 degrees here. If you use a little calculator in your head, that's what you'd come up with. So here you have several criteria for left atrial abnormality. You have a leftward axis of the P wave. You have a very large negative deflection in V1. And to some degree, the P wave duration is a little bit long, at least in some of the leads. In the next video, we'll cover right atrial abnormality as well as biatrial abnormality, which simply means that you have criteria for both left and right atrial abnormality in the same patient. Until then, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey, this is Dr. Nick with the Ecg Academy. To finish up this section of atrial abnormalities, we'll talk about right atrial abnormality and biatrial abnormality. So just as a quick review, the P wave, of course, comes from depolarization from the sinus node, and the right atrium depolarizes down and to the patient's left, giving rise to the initial part of the P wave. Bachmann's bundle behind the heart allows the electrical signal to travel to the left side, but left atrial activation again occurs down into the patient's left, giving rise to the second part of the P wave. It's the sum of these two parts that gives rise to the P wave in its entirety. Now, in left atrial abnormality, we talked about the left atrium enlarging and resulting in a more predominant second part of the P wave, giving rise to things like P mitrale, and in V1, a predominantly negative deflection going away from the anterior chest wall, because after all, the left atrium is a posterior structure. Well, now in right atrial abnormality, we're going to talk about what happens when the right atrium enlarges. So imagine if the right atrium becomes very enlarged. It's going to take much longer for that wave of depolarization to travel across this atrium. And so the first part of the deflection, the first part of the P wave, is going to take longer, and it's going to create a higher voltage. And so what happens in the inferior leads, where this very large atrial signal is traveling, is that the P wave in the inferior leads grows very large. It becomes somewhat peaked, and the definition of right atrial abnormality generally is accepted that the P wave is greater than 2.5 millimeters in the inferior leads. So what you'll see is a P wave that's greater than 2.5 millimeters in size in the inferior leads before it gives rise to the QRS complex. Now, this would be in lead 2, 3, or AVF. The other criterion that we use to diagnose right atrial abnormality is a significant positive P force in V1. Remember, if this is the chest wall cut in half with the spine in the back and the sternum in the front, the right atrium is more anterior, whereas the left atrium is more posterior. So with enlargement of the right atrium, you have more forces heading towards V1. And so V1 winds up with a very large positive deflection, consistent with right atrial abnormality. In biatrial abnormality, what you see is characteristics consistent with both right and left atrial abnormality. So in V1, what you'll see is a large positive and a large negative deflection. And in the inferior leads, you can see a tall P wave, but it's also wide, and it may have a double bump to it, with the two bumps being separated by at least 40 milliseconds. So those are the criteria that we use to diagnose right atrial abnormality and biatrial abnormality. Here's the first example. And when you first look at this ECG, you see it's fairly regular. The rate's just under 100. You have upright P waves. You have upright P waves in lead 1 and also in AVF, but they're very large in lead 2 and also 3. If you take calipers to it, it's just about 2.5 millimeters in size. When we calculate the atrial axis, we can see that AVL is just slightly negative and lead 1 is just slightly positive, so the isoelectric will be somewhere in between 1 and AVL. So if lead 1 points to 0 degrees and AVL is at minus 30, then this axis is perpendicular to minus 15. If you add 90 to that, you get plus 75, and that would be the P wave axis. Now, there's a double bump in the inferior leads, but it's less than 40 milliseconds apart. So I would consider this consistent with right atrial abnormality, and the voltage here is consistent with LVH. Actually, that's what we're going to cover in the next section. Let's go on to the next example. Here we have a patient with sinus tachycardia. The rate here is about 110 or so. The P waves are upright in 1 and AVF, again with a P wave axis of about plus 75. Now look how tall the P wave is in lead 2. It's at least 3 millimeters here, and so that's consistent with right atrial abnormality. But if we then look at V1 to see if we have a positive deflection, we see that the deflection is predominantly negative. In fact, the negative deflection is more than 1 millimeter long and greater than 1 millimeter deep, and this is consistent with left atrial abnormality. So when you have criteria for both, you're allowed to diagnose biatrial abnormality, and this patient certainly fits that bill. I have one that's even more impressive next, and this is a great example of biatrial abnormality in a patient who has some congenital heart disease. Now look at the size of those P waves. They're enormous. And look at these negative deflections in V1 and V2. They're likewise gigantic. When I'm going to zoom into lead 2 so you can see a little bit more detail. So ideally what you want to do is find the baseline, and the baseline most of the time is the segment between the T wave and the following P wave. So if this is the baseline, how far off the baseline is this P wave? Well, I measured just over 4 millimeters. And that's an impressive example of right atrial abnormality. And you can see these negative P waves from across the room, so the left atrial abnormality is really very impressive as well. Well, that just about completes my discussion of atrial abnormalities in this intermediate section of the Ecg Academy. I want to thank you for listening and for subscribing. And as I mentioned before, the next section deals with hypertrophy, which is a very common finding in 12-lead ECGs. So until then, this is Dr. Nick for the Ecg Academy. Thanks for watching.
This is Dr. Nick of the Ecg Academy. We're going to pump you up. That's right, we're talking about hypertrophy.
So this section's about hypertrophy and how to diagnose it on the cardiogram. So think of hypertrophy as like really thick muscles. And if you think this is me, well, then my skills in Photoshop are better than I even thought. So let's talk about the heart muscle and what happens in hypertrophy. Well, hypertrophy is a situation where the ventricular muscle is thickened for some reason. There's a lot of different reasons for it, but the heart muscle becomes very thick. And if you measure it on an echocardiogram, the thickness that we measure generally exceeds 1.1 centimeters. So you have a very, very thick heart muscle. It can be because the heart is working too hard, for example, in severe hypertension or someone who has aortic stenosis. So the heart has to work a lot harder to pump the blood either against a high pressure or against a gradient that the aortic valve is producing. And just like the bodybuilder that I showed you, the muscle gets thicker and heavier in order to accommodate for the increased workload. Well, you can imagine that a thicker heart muscle is going to generate more voltage. And that's generally what we're going to be looking for when we go to diagnose hypertrophy. Now, you can have left ventricular hypertrophy or right ventricular hypertrophy. Left is going to be this video, and right I'll cover in the next video. It's usually easy to diagnose this, but there are certain criteria that we look for to be able to say whether probable or definite LVH is present. So the criteria that have been devised are based on a number of different features that are seen when the heart muscle becomes excessively thickened. Voltage criteria are very important. Because the muscle is thicker, it generates a larger amplitude signal, and we'll go over the different voltage criteria that are used. The normal axis can often shift leftward because you have this very large electrical signal that's headed towards the left side of the heart, and so left axis deviation is one of the criteria that we use to diagnose LVH. Now, what do we mean by strain changes? Because of the thickening of the heart muscle, repolarization abnormalities can occur. Normally, we see the ST segment is isoelectric and the T wave is going in the same direction as the QRS complex. In strain, what we see is the QRS is usually of a larger amplitude and the ST segment deviates in the opposite direction from the QRS complex. So if the QRS is up, the ST segment is usually flat and depressed and sometimes will slope downward away from the QRS complex. And the T wave will often be either inverted or biphasic. So this is what ST segment strain looks like. It's depression of the ST segment, kind of a curving or coving of that with inversion of the T wave. In a lead where the QRS is normally down, such as V1 or V2, what you'll see is ST segment elevation. And so the STs are basically deviating in the opposite direction from the QRS complex. When the QRS is up, the ST is down, and vice versa. So that's what strain means, and I'll show you examples of that. Left atrial abnormality occurs because in response to the thickening of the left ventricular wall, what happens is the compliance of the left ventricle is reduced. In other words, the ventricle becomes stiffer. The compliance refers to the heart's ability to relax and receive the blood coming in from the atria, and how much pressure is actually required to get that blood into the left ventricle. When the ventricle becomes thickened or hypertrophied, it becomes less compliant. In other words, it becomes more stiff, and it takes a higher pressure of blood to fill that ventricle up. So what happens is the pressure in the left atrium increases, and as a result, you can get dilatation of the left atrium, and that results in left atrial abnormalities. And finally, widening of the QRS complex is sometimes seen in LVH just because it takes longer to get around the heart when there's such a thick heart muscle present. As far as the scoring system is concerned, the most common one used is called the Estes criteria. And here it's a point system, and you're given points for different findings on the ECG. If you get 5 points, then they say that LVH is present. And if you only have 4 points, well, then it's probable. But 5 or more gives you LVH, and let's look at the point scoring. And this is something that you can refer back to, and this is published in many different websites, as well as in most ECG books, but you kind of have to just memorize it. If the R or the S wave in any limb lead is greater than 20 millimeters, or if you have an S wave in V1 or V2, that's a negative deflection. If the S wave in V1 or V2 is more than 30 millimeters, that's 6 large boxes. Or if the R wave in V5 and V6, which would normally be up, is greater than 30 millimeters, then you get 3 points for that voltage criteria. If you see left axis shift, you get 2 points. Strain changes are very important. You get 3 points for strain changes. Left atrial abnormality gets you 3 points, and widening of the QRS, or some people say delayed intrinsicoid deflection in V5 or V6, where the peak of the R wave in V5 and V6 is delayed, that gets you an extra point. And you only need 5 points or more to be able to call LVH. Now, I just want to mention there are other voltage criteria that are commonly used that are not part of the ST system. And here they are, just quickly listed. An R wave in AVL of greater than 11 millimeters is often considered minimum voltage criteria for LVH. Greater than 13 is usually a little bit more specific for it. If you take the R wave in lead 1 plus the S wave in lead 3, and you add them together, if it's more than 25 millimeters or 5 small boxes, then LVH is present. And then finally, if you take the S wave in V1 plus the R wave in V5, or the S wave in V2 plus the R wave in V6, if that exceeds 35 millimeters, then LVH is said to be present. Well, let's get to some examples of this. Now, here's an ECG. It's pretty straightforward. It's regular. The rate's about 85 beats per minute. The PR interval is normal. The P is up in 1 in AVF. So we have a normal sinus rhythm. But the first thing that I notice is that the voltage is pretty generous here. If you take the size of this R wave, it's about 22 millimeters, which fits the ST's criteria and gets you 3 points. If you take the other criteria, you add the 22 plus another 14 here, you get 36, and that meets the other criteria, plus you have about 16 millimeters in AVL. So just based on the limb leads, you definitely have voltage criteria for LVH, and most people would call this. You don't have any of the other ST's criteria. So some people would simply call this probable LVH. Especially in a young person, this may just be a normal variant. So be careful, voltage alone does not always give you the diagnosis. Here's another example. Again, we have a normal sinus rhythm. The rate here is about 65 to 68 beats per minute. Again, notice the really tall amplitude in AVL. Plus you have a very deep S wave here. It's more than 20. So you get 3 points in the ST's criteria. But notice that the QRS is wide. You've got this nonspecific IVCD that's going on. Plus, you have the beginnings of some strain changes. You have a little bit of ST segment depression in 1 in AVL. You have a tiny bit of ST segment elevation in these leads where the QRS is going down, so your ST segment is deviating upwards. You now have a left axis deviation with lead 2 being most isoelectric, so you're about minus 30 or minus 40 in your axis. You have left atrial abnormality, and if you take the R wave in V2, which is about 25, plus the S wave in V6, which is about 18 or 19, you clearly have more than 35 millimeters there. Plus, you can see the strain changes with the ST segment depression and the biphasic T waves with clear evidence of ST elevation in V1, V2, V3. So this pretty much gives you every single point, and this is definitely LVH. Here's one last example, a little bit more subtle. It's a normal sinus rhythm. You have a left axis deviation of minus 30 with it being isoelectric in lead 2. The QRS is a little bit widened. You have just a tiny bit of strain changes in the T waves here. Definitely strain here with ST depression and inverted T waves. It doesn't quite make 25 millimeters in V6, but if you add V5 plus V1, I think you'll just about make 35. You've got left atrial abnormality. In fact, you also have right atrial abnormality, so this biatrial abnormality here. And you certainly have enough criteria to diagnose left ventricular hypertrophy. Well, this is something that you just have to practice. Keep those criteria in mind. Sometimes you write them down on a little cheat sheet in case you forget, but it's generally a pretty easy diagnosis to make on a 12-lead ECG. In the next video, we'll go over right ventricular hypertrophy, and that'll complete this section in the intermediate level of the Ecg Academy. Until then, this is Dr. Nick. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this video is about right ventricular hypertrophy. We talked about the left side in the last video. So what happens if the right ventricle gets large? Well, any enlargement of the right ventricle is going to wind up causing specific changes in the cardiogram. Although it's not as common as left ventricular hypertrophy, you still have to be able to recognize it. So what kinds of things will make the right ventricle enlarge or become thickened? Well, here are the most common causes of right ventricular hypertrophy. Pulmonary hypertension occurs when the blood pressure in the pulmonary arteries is excessively high, and the right ventricle has to work harder to push that blood through the lungs, and so the RV enlarges and the walls become thicker. Pulmonary embolism occurs when a blood clot goes down the lungs and occludes part of the pulmonary circulation, so suddenly the resistance to blood flow increases dramatically, and the pressure in the pulmonary artery suddenly increases. This puts a lot of strain on the right ventricle, and the right ventricular chamber can enlarge quite rapidly and lead to signs of RVH on the cardiogram. Chronic lung disease affects the right ventricle because the RV has to pump the blood through the lungs, and when you have diseased lungs, it can cause right ventricular problems. Congenital heart disease, in particular pulmonic stenosis, where the pulmonary valve is excessively narrow, then the right ventricle has to work harder to push the blood through the valve. Mitral stenosis results in increased pulmonary pressures because the mitral valve has such a small opening that the blood has a hard time getting through it, so the left atrium enlarges and the pressure backs up into the lung circuit and winds up resulting in increased right ventricular pressures and pulmonary hypertension. And finally, an unusual heart muscle problem that primarily affects the right ventricle, and it can lead to ventricular arrhythmias arising from the right ventricle. It's known as arrhythmogenic right ventricular cardiomyopathy, or the older name is arrhythmogenic right ventricular dysplasia. So what happens with RVH is that instead of the axis traveling down and towards the patient's left, you have much more electrical activity this way. Normally, we don't see much of the right ventricle on the cardiogram. But when the right ventricle enlarges or becomes thickened, the electrical axis tends to shift rightward, and that's a very common finding. Remember that if we look at the chest in cross-section, with the spine in the back and the sternum in the front, the right ventricle is an anterior structure, whereas the left ventricle is more posterior. And since V1 and V2 are looking at the front of the chest wall, you'll see tall R waves in V1 and V2 because of all the voltage that's traveling towards the front of the chest. Conversely, V6, which is out here, and V5 are seeing electrical signals traveling away, and so in those leads you'll often see a persistent deep S wave. So this S wave corresponds with abnormal electrical signals that are traveling away from V5 and V6. You can see strain changes in the leads over the right ventricle. And it's also common to see right atrial abnormalities because the thickened wall and the enlarged right ventricular chamber and the high right ventricular pressures get transmitted to the right atrium, and the right atrium winds up becoming large. So you get right atrial abnormalities that go along with this. And widening of the QRS can occur in severe cases as well. So specific findings, specific criteria include right axis deviations. Some texts say greater than 90 degrees and some say greater than 110. If the R wave in AVR is greater than 5 millimeters, or if you have a tall R in AVR, that tells you that your axis is markedly rightward. In V1, if the R wave is larger than the S wave, that means the RS ratio is greater than 1. That goes along with RVH. And specifically, if the R wave is greater than 7 millimeters in V1. You can sometimes see a QR pattern in V1, but if you see an RSR prime with a widened QRS complex, then that goes more with a right bundle branch block. So you shouldn't really call RVH if a right bundle branch block is present. If you add the R wave in V1 plus the S wave in V5 or V6, if it's greater than 10, that goes along with RVH. And if you have deep S waves greater than 7 millimeters in V5 or V6, that goes along with RVH as well. But make sure that you're not seeing just late transition. So if you see V1 has no R wave at all, and then all you have is a residual S wave in V6, that goes more for late transition rather than right ventricular hypertrophy, especially if the axis is normal. Well, I just have a couple of examples because it's not a common diagnosis. And this is sort of iffy, but it's an example of a tall R wave in V1 and V2. This is clearly greater than 7 millimeters with a ratio greater than 1. You don't have much of a residual S wave in V6, and you really don't have right axis deviation. The axis here is still in the normal range. So that's why I say you have to be really careful. Sometimes this is just lead positioning, and sometimes it's just considered early transition. But early transition is usually associated with hemiblocks, and we'll talk about that in the videos a couple of sections from now. But just be aware that these positive going R waves in V1 and V2 do show excessive right ventricular activation in this cardiogram. I think this is a much better example. This is a sinus rhythm. The P waves are up in 1 and they're up in AVF. Be careful because sometimes when you see this markedly negative QRS complex with a negative P wave, then sometimes what you're dealing with is the left arm and right arm leads have been reversed, and what you're actually seeing is a normal lead 1 that's just upside down because the black and white leads were placed on the wrong limbs. But here the P wave is clearly upright, so that's less likely. Lead 2 looks most isoelectric, although AVR is a close second. So if you're looking at the axis with this being 1 and 2 is down and to the left, it's going away from 1, so it has to be perpendicular to lead 2, and that would make the axis out here someplace. I think it's a little less than that, perhaps 145 degrees, right? Because if it was isoelectric in lead 2, that would be plus 90 plus another 60 is 150. But AVR over here would make this 120 degrees, and it's clearly positive in AVR, so it's not halfway between AVR and 2. It's closer to 2. Plus 145, I think it mathematically is probably the best number to use. And what you have here is a tall R wave in V1, and you have a very deep S waves in V5 and V6 that easily meet the criteria of a total of 10 millimeters between the two of these, or greater than 7 millimeters in either one. Plus the P wave here in lead 2 looks to be just about 2.5 millimeters, so I think that right atrial abnormality is also present, although it looks like you have left atrial abnormality as well. So try to look out for right ventricular hypertrophy. It's not a common diagnosis, but you do need to be able to recognize it. In the next section, we're going to be talking about interventricular conduction delays in more detail than we did in the basic course, because I want to make sure you know how to make the diagnosis of right and left bundle branch blocks. And then following that, we're going to get into hemiblocks and then ischemic heart disease. Well, until then, this is Dr. Nick with the Ecg Academy. Thanks for watching.
That's right. The tree's dead there. Gonna have to cut that down.
Hey, this is Dr. Nick with the Ecg Academy, and we're going to be talking about branches, dead branches, bundle branch blocks this section. The first video is going to be about right bundle branch block, and I saw a picture of this tree, and I thought, what can I do with this? So what I did was I flipped it upside down, and kind of reminds me a little bit about my conduction system, the branches in the left ventricle that supply the signal to the myocardium. And since we're going to be talking about bundle branch block, it deals with disease of these bundles. So, okay, it's a little bit of an obscure connection with the disease tree, but let's get to it. Most of you have already watched the videos in my basic course, so you're familiar with the electrical system of the heart, with the sinus node that gives rise to the P wave as the signal spreads across the atria. And then the signal enters the AV node, gets delayed for a split second, and then is passed down through the bundle of His and the bundle branches, which results in depolarization of the ventricles. It gives rise to the QRS complex. Well, recognizing conduction system disease is not difficult, but you have to understand what the QRS complex looks like, and I did touch on this in the basic course, but we'll go into more detail. First of all, a very important concept is that the bundle branches are made up of specialized cells, long heart muscle cells that are designed for very rapid conduction velocity. These cells bring the signal down to the ventricles in a very rapid, efficient manner. The conduction velocity is literally meters per second. And if everything is working properly, if the right side of the heart and the left side of the heart get the signal more or less at the same time, the whole entire heart winds up contracting in a very efficient manner. And so what you get is a very narrow QRS complex. The normal QRS duration is usually 80 to 100, maybe 110 milliseconds. Anything greater than 120 milliseconds is consistent with some kind of conduction system disease, and you usually start looking for a bundle branch block with that. The reason the QRS becomes wide is because when one of the bundles is diseased, the signal doesn't get down that bundle efficiently. And instead what happens is the signal goes down the contralateral or the opposite bundle. And then the myocardial depolarization finds excitable cells, and the cells pass the signal from one to another like a bucket brigade fashion in order to depolarize the opposite side, which did not get the signal in time. The important concept to realize is that the bundled branch doesn't have to be blocked in order for the QRS to become widened. The key is that one of the bundles has to be a little slower than the other. And then you'll get this phenomenon where the QRS takes longer to inscribe because the signals are going down slower cell-to-cell connections instead of the rapid Purkinje system. But it doesn't have to be blocked. So the word block is a little bit of a misnomer. And I'm sure you've heard of incomplete bundle branch blocks. Well, what does incomplete mean? It's like being a little pregnant? No. You see, the word block simply implies delay. And so you can have a little bit of delay, or you can have a lot of delay. And that's going to affect how the QRS looks, and obviously how wide the QRS is going to be. Okay, let's get a little bit more specific. If we're looking at the limb leads 1, 2, and 3, generally if you have a normal QRS complex, a normal QRS is going to be up in 1, and it's going to be up in AVF, assuming that you have a normal axis. Lead 2 will generally be a little bit taller than lead 1 because the axis usually runs in this direction down and to the left. And lead 3 will often be a bit smaller because lead 3 is looking in this direction. Now we're going to talk about a right bundle branch block first. And so what happens when the right bundle doesn't conduct properly is that the electrical signal travels through the left ventricle normally. And so the initial part of the QRS complex stays the same. But then the right ventricle depolarizes late. Now where is the right ventricle located? It's located on the right side of the body, but also anterior. So if I were to draw the chest here with the sternum in the front and the spine in the back, the right ventricle is more in the anterior part of the heart, and the left ventricle is more posterior. Okay, so when the right bundle is blocked to any degree, you have the latter part of the QRS complex later signals after the left ventricle has completed its sequence of activation. Now you have the right ventricle depolarizing later, and where does it show up? Well, it shows up on the lateral leads because after all, lateral leads like lead 1 are looking, remember lead 1 is from right arm to left arm, and so it's looking for signals that are going towards the left side. And since the right ventricle is on the right side and signals are traveling away, what's going to happen is that you're going to wind up seeing late signals in the lateral leads. So what you'll see is a negative signal on the tail end of the QRS complex. Why is it so small? Because the right ventricle is relatively thin and it doesn't generate a lot of electrical current. Why is it wide? Because these signals are traveling slowly from cell to cell and it takes longer to get around the right ventricle. And why is it negative? It's negative because these signals are going in the opposite direction than where lead 1 is looking at, and so it's inscribed as a negative signal. So you can imagine that AVL is going to look much like lead 1. In fact, they usually look the same because they're both looking at the lateral wall of the heart. So AVL is going to look this way, 30 degrees above the horizontal. Now, how will that look in the inferior leads? Well, it really kind of depends on the axis, but it's not uncommon for people to see wacky delayed signals in the inferior leads because, after all, the QRS duration now has widened. You're looking at 120 milliseconds or greater for a right bundle branch block, and so in lead 3, there's going to be a late signal here. It's not exactly consistent because the signal kind of goes towards the feet, but then it kind of goes away from the feet as the vector traverses the right ventricular free wall. So there generally is not going to be a consistent appearance to the inferior leads. But the lateral leads will be very consistent with this negative what we call a broad S wave in the lateral leads that's 1 in AVL. Now, what about the precordial leads? What about V1 through V6, V2, V3, 4? Well, remember, V5 and V6 are also lateral leads, and they're going to look just like 1 in AVL with a fairly normal P wave. The beginning part of the QRS should look normal because that represents left ventricular activation, but there's going to be a wide S wave as classic pattern for a right bundle branch block. Now, what's V1 and V2 going to look like? Well, these are actually the easiest ones to recognize. Because the right ventricle is anterior, it's actually very close to V1 and V2, and so the signals from the right ventricle tend to be relatively large. Now, normally, what should V1 look like? If you remember from our basic course, V1 should have a small septal R wave and then a deep S wave, followed by an upright T. Just as a review, that septal R wave occurs because the septum is generally depolarized off the left bundle, and so the septal depolarization travels anteriorly and to the patient's right. So you get a positive going deflection initially in V1, that little tiny R wave, and that's also what explains these little tiny Q waves in the lateral leads, such as I've drawn here in V5 and V6. This little tiny Q wave is a negative deflection as the septum depolarizes and the signal goes away from V5 and V6. You get this negative signal that's a Q wave. So you get the septal R wave in V1, and then you have a normal QRS complex in general. But now what happens in a right bundle branch block is that you get these late signals traveling towards V1 and V2 because the right ventricle is depolarizing late. And so what you get is this positive deflection, which corresponds with the S wave in 1 in AVL, V5 and V6. But in V1, it's a positive deflection. If I redraw it, it's known as an R prime. It corresponds with the S wave here. But because the signal is going towards V1 and V2, it's a positive deflection. It's also very common for the T wave to become inverted because when the sequence of depolarization is thrown off, the sequence of repolarization is usually thrown off. So instead of having an upright T wave, with the right bundle branch block, there's usually a negative T wave. Now this RSR prime pattern, the relationship between the left and the right ventricular masses and the timing between the two ventricles can look like this, or it can sometimes have a more prominent R prime pattern, and in fact, on occasion, you'll see notching like this when the R wave is taller than the S wave. And we'll see different examples of this in the next few slides. Okay, but this is just a physiologic explanation as far as why a right bundle branch block looks this way. Okay, well, let's get to some tracings. Okay, so here's a normal sinus rhythm at a rate of about 70 beats per minute with a normal PR interval. And when you look at the QRS complex, it looks almost normal. I think if you measure it, it winds up being about 110 milliseconds. And it's upright in 1 in AVF, so the axis is normal. But when you glance at the precordial leads, this is where you'll see this R prime. You have an RS R prime pattern. You can see the R prime also in V2. However, the QRS duration is not long enough to call this a right bundle branch block because the right ventricle is not depolarizing that much later than the left side. So what you have is just simply delay in the right bundle branch. Some people will call this a right interventricular conduction delay, but most cardiologists will go ahead and label this an incomplete right bundle branch block. Again, incomplete block is a bit of an oxymoron. Hey, who you calling a moron? But this is a typical example of a right IVCD. Now, if you notice, there is a little bit of an S wave that's prominent, especially here, but it's not terribly wide. Well, the next example is a little bit more of a classic right bundle branch block pattern. Here, you have a little bit faster heart rates, about 105 or 110 beats per minute. When you look at the limb leads, you see there's a very nice broad S wave here in 1 and AVL. Even the voltage is a little bit low. And you have a beautiful RSR prime in V1 and V2 and even V3. The R wave is very small and it grows, and so the R wave progression is normal. The total QRS duration here is about 130, maybe 140 milliseconds. And so we would call this a right bundle branch block. It's classic. You should never miss this. Again, you've got that little S wave there in V5 and V6. This is sort of a classic moderate degree right bundle branch block. But if you have more delay in the right bundle branch, you can get these very large R prime signals in V1 and very wide S waves here in lead 1 that's actually bigger than the R wave. Again, the QRS duration here is only about 140 milliseconds. But you're starting to see a little bit of a right axis deviation. You see the axis here? It's isoelectric in 1, so the axis is about plus 90 or so. But as we'll see in the next section, it's common to have evidence of other conduction system disease in combination with a right bundle branch block pattern. Well, the last example I came up with is this one where you've got this huge positive deflection in V1 that in essence is an RSR prime, but they're both going up and it's only a little bit of a notch here. And you got this humongous S wave in 1 in AVL representing a marked right axis deviation. If the QRS wasn't so wide, you might even call this right ventricular hypertrophy. So if the QRS was less than 120 milliseconds, you have right axis deviation, you have a tall R in V1, and you have a pretty big S wave in V6. You could call this RVH, but because the QRS is wide, in this case about 160 milliseconds, you really have to call this a right bundle branch block and right axis deviation consistent with a left posterior hemi block. But I don't want to give away the next section, so just forget I said that. Anyway, recognizing a right bundle branch block is actually quite easy, but understanding why it looks this way when you're going forward, because understanding the physiology is what makes you an ECG expert. And after all, that's why you've subscribed to the Ecg Academy, isn't it? Well, anyway, this is Dr. Nick for the Ecg Academy. In the next video, we'll go over left bundle branch block in the same way. Well, until then, thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and we're going to talk about left bundle branch block in this video. When we spoke about right bundle branch block, I mentioned how important it is for you to understand the concept that the word block doesn't necessarily mean a complete block. Sometimes, of course, there's a refractory period, and if the AV node lets a signal down at a point where the cell has not yet recovered, that part of the conduction system will fail to conduct the signal. In the basic course, we talked about functional bundle branch blocks, where the signal is able to get down one side, but the other side happens to be refractory. But I think it's useful to think of bundle branch blocks as not so much black or white, but rather that a bundle branch block will appear on an electrocardiogram if one side of the conduction system delays the signal with respect to the other side. So if you simply have delay in the left bundle branch system, then the wave of depolarization is able to get to the right side of the heart, and then it's basically a race between the delayed diseased conduction branches and the intramyocardial slow cell-to-cell conduction, kind of like a bucket brigade. Now, both means of conduction are slow, but depending upon which one is slower, that will determine what the QRS complex looks like. And so you have a spectrum, anywhere from a narrow QRS complex to a very wide, bizarre, typical left bundle branch block QRS, and a whole bunch of things in between. That's why some people use the term incomplete left bundle branch block to designate an ECG that looks kind of like a left bundle branch block, but it's not wide enough to meet the criteria. So understanding the physiology does help you interpret the electrocardiogram, but keep in mind there's no line in the sand that necessarily establishes normal versus abnormal. It's much more subtle than that. Well, if this doesn't sound somewhat familiar to you, you should go back to the basic course and listen to the videos on aberrant conduction, because that does talk more about refractory periods and bundle branch blocks and so forth. Okay, well, having said that, let's talk specifically about how we diagnose a complete left bundle branch block. You should recall that the septum of the heart depolarizes primarily from left to right because it's the branches of the left bundle that depolarize the septum in that direction. So when the left bundle branch does not depolarize properly, you wind up losing evidence of early septal depolarization. Now, what is early septal depolarization? Well, in the lateral leads 1AVL, V5, and V6, a normal QRS complex should have a small Q wave, because the initial deflection is away from the lateral leads from left to right. So you get this negative deflection because it's going away from the lateral leads. Then, of course, the majority of the left ventricle is on the left side, so your vector is mainly down and to the left. You get this very tall positive R wave, and then sometimes a small S wave. Well, in a left bundle branch block, first of all, you lose that early septal activation. Not only that, but it takes so much longer for the signal to go through those intramyocardial pathways that the QRS winds up looking very wide. Generally, to make the diagnosis of complete left bundle branch block, you need at least 120 milliseconds. So you lose that septal Q, you have a relatively slurred upstroke, and it's not uncommon to see notching of the QRS complex in the lateral leads. This is very typical of a left bundle branch block with a QRS duration of greater than or equal to 120 milliseconds. So that's in the lateral leads. That's what it looks like. In the precordial leads, keep in mind that V1 is here to the right of the sternum. Here's the spine. The heart is lying in the chest with the right ventricle anteriorly. We know that, right? And the left ventricle is posterior. So you have a lot of posterior forces coming late. Septal activation, which normally should give you an anterior vector, in V1, that will look like a small R wave. And then the rest of the QRS complex is fairly narrow. It very quickly gets around the ventricle and heads back towards the base again. So it doesn't take long for the signal to turn around. And that turnaround point of the signal is known as the intrinsicoid deflection. Think of it as the bottommost part of the QRS complex in V1 and V2. Generally, what you see is the intrinsicoid deflection is around 40 or 60 milliseconds after the onset of the QRS complex. In a left bundle branch block, you often lose that septal Q wave, and so what you have is a QS pattern. It's wide, and the intrinsicoid deflection, which is the part where the QRS complex turns around, is often at least 80 milliseconds after the onset of the QRS complex. So what that tells you is that this downward sloping QS wave, this part that's going down, is slurred. It takes a while to reach its lowest point before it turns around and comes back again. It's just an indication of the wave of depolarization taking a long time to get around the heart. So you have a wide QRS, you have loss of the septal Qs in the lateral leads, usually a loss of the R wave in V1, where you have just a QS pattern, although sometimes you can get a little tiny R wave there, and then delay of the intrinsicoid deflection in the anterior precordial leads. So those are the criteria. And I did put together an animation that shows you what happens to the wave of depolarization. It goes down the AV node here, and then goes down the right bundle branch, and then has to slowly make its way over to the left side. So that gives you an idea of how disturbed the wave of depolarization is as it gets around the heart. Clinically, people with left ventricular dysfunction don't do well with a left bundle branch block because it disturbs the synchronous activation of the left ventricle. And what happens is septal activation does occur before the lateral wall. And you got left ventricular dyssynchrony with an inefficient contraction of the left ventricular walls. This can lead to worsening of heart failure, enlargement of the left ventricle known as remodeling. And nowadays we use a special kind of pacemaker known as a biventricular pacemaker to provide what's been called cardiac resynchronization therapy. And these are known as biventricular pacemakers. And sometimes you can get an implantable defibrillator that has a biventricular pacing system in it as well. And that's used to treat congestive heart failure in patients with a left bundle branch block that has resulted in mechanical dyssynchrony between the two walls of the left ventricle, the septum and the lateral wall. Well, at this point, let's get to look at some tracings. Here's an example of a classic left bundle branch block pattern. You can see the QRS is very wide. Here it's about 180 milliseconds in duration. The axis is leftward. You can see it's most isoelectric in lead 2, but it's more negative than it is positive. Remember, lead 2 is down and to the patient's left. 90 degrees from that would give you minus 30, but because it's more negative than positive, it's going further away from the feet, so it's probably about minus 40. Left axis deviation is quite common in a left bundle branch block. You could see the notching in the lateral leads, a little bit of a knee here in lead 1, more of a knee in AVL, and you can see the notching in V5 and V6. And you can also see that there is no Q wave, no septal Q wave in the lateral leads. It just goes straight up. It's just a pure R wave with no septal Q. In V1 and V2, you do have a little tiny micro R wave there, which you can sometimes see, but the QRS is quite wide. And if we look at V1 very closely, we can see the QRS starts on this line here, which is 80 milliseconds after the heavy line. And the intrinsic coil deflection is about 80 milliseconds, maybe 70 milliseconds after the onset of the QRS complex. So that's rather delayed, and you can see this negative S wave here is not exactly steeply negative, that there is a little bit of a slope to it. And again, here in lead 1 and AVL, you see there's no septal Q wave, and so this is a pretty classic left bundle branch block pattern. I'll show you one more example. And this is a 12 lead where you can see some beautiful notching in 1 AVL and as well as V6 here. The transition is a bit late here. You can see that you have a QS pattern all the way across the precordium, and it's not until V6 where it becomes this typical positive upright notched pattern. The QRS complex is clearly wide, about 150 milliseconds here. There's again a left axis deviation and absent septal Q waves in the lateral leads, and here there's no R wave in V1 or V2 as well. So it's usually pretty easy to make this diagnosis. But in the next video, I'm going to talk about nonspecific interventricular conduction disturbances, which some people would label as atypical or incomplete left bundle branch blocks, and that will finish our discussion. Until then, this is Dr. Nick with the Ecg Academy. Thanks for watching.
Hello, this is Dr. Nick for the Ecg Academy, and we're playing some Italian music right here, right now, because it looks to me like the cardiac conduction system is more like the subway map to Milan. I had to start this video on a lighter note because, after all, the subject of other interventricular conduction delays just sounds a little dry, so I thought I'd liven things up. You have to figure that a nonspecific IVCD is kind of like if the line to Abbiate Grazzo is not working so good. This got a little power failure here, so you got one part of the heart that's not getting the signal properly. And so what happens is it takes a while for the electrical signal to get around the heart, and so the QRS complex is generally around 120 milliseconds or longer. Now, some people will use the term IVCD to designate a QRS that just doesn't look right. It kind of looks funny, but the QRS complex is maybe only 110 milliseconds, and we're generally talking about non-specific IVCDs, but I'm going to try to confine my comments to QRS complexes greater than 120 milliseconds, but they're not a left bundle branch block, they're not a right bundle branch block. Instead, they're non-specific IVCDs. Okay, so not this, we're going to talk about this. So with this 12 lead, when you first look at it, you get a sense that, are we thinking about something, some kind of problem with the QRS complex? Because it does look a little bit wide. It's probably about 110 milliseconds to 120 milliseconds long. You've got sort of this deep negative wave here in V1 and V2. You've got a sort of a tall, whitish-looking R wave in the lateral leads, and you have a left axis deviation, of course, with lead 2 being most isoelectric, but it's a little bit more negative than positive. So what do we say? That means it's about minus 40 degrees. Okay, so you'd be tempted to think about a left bundle branch block here, but it's clearly not wide enough, and it doesn't look like a complete left bundle branch block. And what you need to notice right away is that the voltage is enormous. You've got a very big voltage in AVL. You've got deep S's in 2, a tall R in 1. You basically have LVH. Not only do you have LVH, but you've got a strain pattern with ST segment elevation in the leads where the QRS goes down and ST segment depression where the QRS goes up. So the ST segment is deviating in the opposite direction from the QRS. That goes along with the strain pattern.
You've got this left axis deviation. But what you do have here is a widened QRS complex. So LVH is one cause for a widened QRS complex or an IVCD. People would generally read this LVH with strain or LVH with repolarization abnormalities and QRS widening or an IVCD associated with the LVH. Okay, so don't make that mistake. Don't start thinking about left bundle branch block or incomplete left bundle or anything like that when you clearly have LVH. Now keep in mind when we're talking about bundle branch blocks that it doesn't have to be completely blocked in order to affect the QRS complex. If you have disease in the left bundle branch such that the electrical signal takes longer to get down the left bundle branch, the signal is able to go down the right side and then through slow intramyocardial cell-to-cell connections make it over to the left. So then it becomes a race, as I mentioned before, between the delay of conduction down the intrinsic left bundle system and the intramyocardial pathways. And you can have slight widening and you can have very wide QRS complexes and pretty much anything in between. So think of a left bundle branch disease as a spectrum. And if you understand that physiology, it'll make it a lot easier to interpret some of these tracings. Okay, let's go to the next one. Okay, we see here a sinus rhythm. You've got upright P waves in 1 and AVF. You do have a left axis deviation. In fact, here AVR is most isoelectric. So right away you know the axis is going to be minus 60. And when you look at V1, you say, wow, that kind of looks like a left bundle branch block. And 1 and AVL sort of have that widening of the QRS. The QRS duration here is about 140 milliseconds. You can see it's pretty wide here in lead 3. It doesn't exactly have a notch in the top, but it makes you wonder that whether this is some kind of a left bundle branch block type of a thing. Well, clearly the QRS is wide, so it's an IVCD of some sort. And 1 and AVL are reminiscent of a left bundle, but when you look at V6, that doesn't look at all like a left bundle branch block. And when we look at the entire precordial leads, yes, you have a QRS pattern here, but look how steeply this electrical signal goes down. The intrinsicoid deflection is maybe only 60 milliseconds after the onset of the QRS complex. And you have a little micro Q here and a very sizable R. And then here in V3, you've got this huge R wave. And at the rest of the precordium, what you really have is a wide S wave. It almost looks like a right bundle branch block, but V1 certainly doesn't look like a right bundle branch block. It's not a right bundle branch block, and it's not a left bundle branch block. This is a great example of a nonspecific IVCD. It doesn't fit either criteria, but it's wide. And the marked left axis deviation really fits a left anterior hemiblock, which we're going to talk about in the next section. Anterior and posterior hemifascicular blocks. So I won't get into it now, but that's what causes the left axis deviation. So this is a nonspecific IVCD, and that's, I think, the best diagnosis you can give it. Okay, let's go on to the next one. Well, this tracing, when you look at the forest down here in the rhythm strip, it does seem to be kind of bizarre. There is a pattern to it. You've got up, up, down, up, up, down, up, up, down, and this pattern is a trigeminal pattern. The question is, where are these beats coming from, and what kind of trigeminy is it? Well, let's look at the two predominant beats. They do seem to have small P waves, low in amplitude but kind of wide. You can clearly see P waves in V1 and V2. And the P's look like they're positive in 1 and AVF, so we're talking about a sinus rhythm. And then what is this beat? Since we can see the P's here in V1, the next one would have landed right here. We see no P in front of it, so it's not an atrial premature beat, it's a ventricular premature beat. So we have ventricular trigeminy in the middle of this sinus rhythm. Well, when you look at the conductive beats, you say, well, that sort of looks like a left bundle branch blockish looking pattern, but the QRS really isn't greater than 120 milliseconds. It's about 110 to 120. It sort of has a flavor of a left bundle. There's a little bit of slurring of the onset, but it doesn't look like a left bundle here. It does in V6. And I think cardiologists will differ in their opinion of what to label this. But some people would call this an incomplete left bundle branch block pattern because it does have most of the characteristics of a left bundle. It's just not wide enough. Other people will consider it a left type IVCD, and other people will call it just a nonspecific IVCD. And this is one of those diagnoses that you'll see different cardiologists label it differently. Okay, so you have very wide-looking QRS complexes here, and they seem to be quite regular. And when you look at the morphology in AVL, it looks like a classic left bundle branch block pattern, and even in V1 and V2, it looks like a left bundle branch block pattern. Extremely wide, though. Look at that. It's over 200 milliseconds. It's more like 220 or 240 milliseconds in duration. Well, then you start to look for P waves, and you see that what looks like a P wave here, but then it's gone. And then there seems to be no P wave until when you compare this QRS to this QRS, you see there's a small bump in front of it, and sure enough, that bump comes out and marches on through. So there's a P wave that's going on in the middle of this rhythm. You first think that the PR is getting longer, but the R to R interval stays the same, so it can't be second degree AV block. What's really happening is that the atrial rate is significantly faster than the ventricular rate. But then you say, well, where did the QRS complexes come from? Because clearly they're regular. They're also very wide. But what you need to be able to notice is that in the beginning of each QRS complex, there's a little hairy guy right there, and that is actually a pacemaker spike. The pacemaker spike is a little tiny electrical signal that is generated by a pacemaker, and it's what's driving the ventricular rhythm. If you didn't see that pacemaker spike, you might imagine that this is some kind of accelerated idioventricular rhythm because it's so wide, and the rate here is about 65 beats per minute. But in fact, those little spikes, which you can barely see, but they are there, tell you that it's a paced rhythm. It's ventricular pacing going on, and the pacemaker is what's causing the QRS to become so wide. Now, pacing is really an advanced topic, but I just want you to understand a little bit about why the QRS complex becomes wide when a pacemaker is present. So the pacemaker wire is inserted into a vein and sits in the right ventricle, and the most common place for people to place these wires are at the RV apex. So you have this electrical signal that's originating in the right ventricular apex, and then it's spreading outward from there. Well, remember, if you have a left bundle branch block, the signal goes down the right bundle branch and emerges at that point and then spreads gradually over to the left side. Well, that's kind of what happens when you have a pacing wire. If you put it at the RV apex, you've got very slow propagation through the heart emanating from the RV apex, and you get an electrical signal QRS complex that looks identical to a left bundle branch block. This actually can be detrimental to cardiac function, especially when someone has left ventricular dysfunction, because then what happens is the septum depolarizes first, and then a split second later is when the lateral wall starts to depolarize and contract. And you get a sort of an out-of-sync contraction between the septum and the lateral wall that reduces the efficiency of contraction. When I insert pacemaker leads, I always put them on the right ventricular septum. But ideally, in people with heart failure, there's a pacing system known as cardiac resynchronization therapy, or biventricular pacing. But you have another pacing wire that enters the coronary sinus and goes down a branch feeding the left ventricle, and you have simultaneous activation of both sides. The whole pacing technology is kind of complicated, but the point I'm trying to get across is when you have a standard pacemaker in the right ventricular apex, you're going to wind up with a QRS complex that's virtually identical to a left bundle branch block. And don't make that mistake. Look for those little pacemaker spikes in front of each QRS. Now here's the last example I'm going to show you, and it's an unusual cause of widened QRS complex. But if you go ahead and measure this, this is a good 120, 130 milliseconds, and you've got sort of a widened, a little bit of a notching here in AVL. You've got kind of almost a QRS pattern in V1 and V2, but it really kind of doesn't look like a classic left bundle branch block. Now, the thing you have to recognize is that the PR here is very short. And if I take V6 and blow it up, you can see that the PR interval is only about 100 milliseconds. The QRS is about 130, but what you have is virtually no PR segment here. Instead, the QRS complex starts early and you have a very slurred upstroke, It's not a sharp takeoff of the R wave. It's a gradual uptake. And this, of course, is known as a delta wave. And then what you have is ST segment depression and a sort of a biphasic T wave. So this is a classic example of pre-excitation, or WPW syndrome. Wolff-Parkinson-White is due to the presence of an accessory pathway. So here's the heart, you have your atria, you have your AV node here, which gives rise to the conduction system. But in WPW syndrome, there's an extra electrical pathway that connects the atria with the ventricles directly out in the AV groove someplace. In this case, a right-sided pathway that allows the atrial signal to directly pre-excite or stimulate or depolarize the right ventricle earlier than it should, because the AV node would normally delay that signal before it gets to the septum. So this bypasses the delay and results in early activation of the right side of the heart. This is known as an accessory pathway, or a bundle of Kent. And because you have early activation heading towards the lateral side, that's what gives you a positive delta wave in the lateral leads, 1AVL, V5, and V6. So WPW syndrome, or pre-excitation, is one cause of widening of the QRS complex that makes you think a left bundle branch block, but it's not. Just recognize the short PR, the delta wave, and the secondary STT wave abnormalities, and you'll make the right diagnosis. Well, that pretty much completes this section on bundle branch blocks, and I've tried to cover a lot of topics that you'll run into commonly. In the next section, we'll talk about the hemi blocks, which is a confusing topic to many people, but I'll make it as clear as I can for you. Until then, this is Dr. Nick with the Ecg Academy. Thanks for watching.
Hey, so you know what I'm talking about. This is a beautiful piece of machinery, okay? This is a Hemi engine, and if you look at the engine block, the top of the cylinder is curved. It's curved like a hemisphere, with the intake and exhaust manifolds over here, the valves that open and close. So it's the hemispheric curve of the cylinder that makes it a Hemi engine. And this is the block, so it's a Hemi block, you get it? All right, this is Dr. Nick with the Ecg Academy. We're going to talk about Hemi blocks now, all right? So, of course, your heart is like an engine. So when we get rid of the heart and look at the conduction system, we're going to talk about the wiring of your engine and maybe give you a better understanding of why Hemi blocks look the way they do. Well, you know, I've drawn this sort of cartoony diagram of the conduction system, but about 100 years ago, pathologists reported the anatomy of the conduction system is really quite variable. And if I substitute a drawing that they made from a pathological specimen, in this case, there are 3 fascicles that make up the left bundle branch, a very large posterior hemifascicle, an anterior hemifascicle, which was quite a bit smaller, and there was also a branch that fed the septum. But the one thing that was found in this study of a large number of autopsy specimens is that the actual shape of the conduction system is extremely variable. And these were some examples of what they found. So this is the one that I have superimposed on my heart. But you can see that there's almost infinite variations on a theme. But electrocardiographers have described hemifascicular blocks using rather specific criteria, and we'll go over that, but keep in mind that anatomically, it's not always as clear as we make it out to be. Well, to understand hemi blocks, you have to get an idea of the 3-dimensional anatomy of the heart, and that's kind of challenging for beginners, but I'll try to help you through it. If you take this diagram of the heart lying in the chest and imagine someone uses a knife to slice it open in cross-section, and we can do this with 2D echocardiography. We can actually see the heart in cross-section with the left ventricle, which is a more rounder chamber, and the right ventricle, which has a little bit more of a curvy shape. Now, I want you to notice that there are 2 papillary muscles that are indeed connected to the heart. So these papillary muscles are what maintain the mitral valve from prolapsing. So here's the mitral valve, and the edges of the valve leaflets, I'll get rid of that left bundle. The edges of the valve leaflets are connected by tiny little connective tissue strings called the chorda tendineae, and the edges of the leaflets are connected to 2 heavy-duty muscles that come off of the inside of the left ventricle. And these papillary muscles are designed to make sure that the valve does not just blow open into the left atrium. So when the left ventricle contracts
and the valve leaflets close, these papillary muscles are designed to contract, and as the heart chamber size shrinks with the contraction of the heart, it maintains the proper tension on these chordae, and that maintains the proper spatial relationship between the two mitral leaflets. So the chordae are involved in maintaining competence of your mitral valve and keeps your mitral valve from prolapsing and leaking backwards. And when we slice the left ventricle in cross-section, we can see these two papillary muscles. Well, the conduction system runs in close approximation to these papillary muscles. As I mentioned, physiologically, we believe there are 3 branches, although most people don't talk about the septal branch. But imagine that there's a septal branch that runs down the middle of the septum. Then there's an anterior branch that runs across the aortic outflow tract and winds up running near the anterolateral papillary muscle. The third branch, which is the largest, is the posterior hemifascicle, and that emerges in the posterior septal region and winds up giving rise to branches that feed primarily the posterior region, running in close approximation with the posterior medial papillary muscle. With these 3 branches, the inside of the left ventricle can depolarize simultaneously. And as I've mentioned in earlier lessons, the electrical vector winds up running downwards and towards the patient's left. But that assumes that all 3 hemifascicles are firing simultaneously and that the endocardium of the left ventricle is activated nearly at the same time. When one or more of these fascicles is diseased, and by diseased I mean does not conduct as rapidly, there may be conduction delay, then part of the heart may get the signal later than another part, and that disturbs the normal sequence of activation of the left ventricle. Okay, so let's say, for example, and we'll talk about these hemiblocks in detail in the next video. But let's say, for example, there's delay in the anterior hemifascicle such that this blue area gets the signal later than the rest of the heart. So what happens now is the electrical signal travels down the lower part of the heart first because of the septal and posterior hemifascicles activating initially. Posterior medial area of the heart activates first, but then the rest of the heart has to be activated a split second later, and the electrical vector has to turn around by the apex and head back up towards the base. And so what you get is a net shift in the electrical axis. Instead of it heading towards the apex, it winds up turning around and heading back towards the base. In essence, giving you a left axis deviation. And that's one of the criteria for diagnosing anterior hemiblock is a marked left axis deviation. In the next video, we'll get into more detail about what a left anterior hemiblock looks like, but it's really marked changes in the axis that allow you to diagnose disease of the hemifascicles. So for the Ecg Academy, this is Dr. Nick. Thanks for watching.
Hi, this is Dr. Nick with the Ecg Academy, and this video is going to deal with left anterior hemiblock. Now, this is a fairly common diagnosis that I see in maybe 2% of the cardiograms that I read, but a lot of the residents that I teach, they seem to forget the criteria because the criteria is sort of unimpressive, often overlooked. And I find that if you understand why the ECG looks the way it does in left anterior hemiblock, it's much more difficult to forget about it. It's something that you should recognize immediately. And it's actually fairly easy to diagnose, but maybe not so easy to understand. So let's review a little bit, because after all, repetition is the key to learning. So here's our heart cartoon, and you have the AV node here in the atrial septum, and you have the main bundle of His that dives into the central fibrous body and splits into the right bundle branch, which travels down the right ventricular septum in something called a moderator band and then branches out towards the apex. And the left bundle branch, which is much larger, splits into an almost infinite variation of branching points, but functionally we do recognize 3 branches: a large posterior hemibundle or hemifascicle, a thinner anterior hemifascicle, and then a septal fascicle, all of which run on the endocardium of the left ventricle. So the septal branch mainly runs down the ventricular septum and winds up depolarizing the septal region. And remember, the septum depolarizes from left to right. And if you think about the chest in cross-section, with this being the spine and this is the sternum, the right ventricle is an anterior structure, and the septum therefore depolarizes mainly in an anterior direction towards V1. And that's all involved in how an ECG looks under normal circumstances.
Okay, where the anterior hemifascicle runs across the outflow tract of the left ventricle and terminates near the anterolateral papillary muscle. And so the anterior portion of the left ventricle is fed by branches of the left anterior hemifascicle. Finally, the posterior hemifascicle depolarizes the endocardium in this region here near the posteroseptal region. So what happens when you have anterior hemiblock? Well, remember, block doesn't always mean block. It may be seen in cases where the left anterior hemibundle is simply delayed. So you have delaying of conduction down here so that that part of the heart gets the signal later. Well, if this part of the heart, this green part, gets the signal later, what happens is the septum and the posteroseptal region depolarize first, and then the signal has to somehow turn around and reach this part. Now, the QRS generally should not widen because the left ventricle is all connected together, and it's not like the signal is getting from the right side to the left side, such as in a left bundle branch block. In a left bundle branch block, the signal has to travel very slowly through intramyocardial pathways. But in hemifascicular blocks, the Purkinje fibers are fairly well connected, and so the QRS should not get particularly wide. It should remain less than 120 milliseconds in duration, okay? Just remember that. So in a pure anterior hemiblock, what happens is the electrical signal is traveling kind of in this direction from the septum in the posteroseptal region towards the anterolateral wall in this cross-sectional region. And here in this view, more of an anterior view, the signal reaches the septum in the posterior wall and then sort of has to turn around in order to depolarize the anterior region. In this view, the septum depolarizes, and then what happens is the latter part of the QRS complex is heading in this direction towards the lateral wall. So what happens to your QRS complex? Well, the number one biggest change is that you get this marked shift in axis, this left axis deviation of minus 60 degrees or better. Now, some people say minus 45, but that's sort of splitting hairs. Remember, in your circle of axis, your normal axis is going to be down here in this quadrant, and I generally accept minus 15 as still being normal, but when you get to minus 30, which means that lead 2, which is 60 degrees above the horizontal, is isoelectric. When lead 2 becomes isoelectric, then that gives you an axis of minus 30. How do you get to minus 60? Well, there, when you reach minus 60, AVR, which is 30 degrees above the horizontal and headed in the opposite direction, is perpendicular. So that's the key. The first place you should look is AVR. If AVR is isoelectric or positive, then you know that the axis is going to be in this half of the circle. And so the axis, therefore, is going to be markedly abnormal. So if AVR is isoelectric or positive, then that meets the criteria for hemiblock. And then the question is it anterior or is it posterior? In an anterior hemiblock, being that the axis is markedly leftward, the inferior leads 2, 3, and AVF should be negative. So the inferior leads are negative because the signal is going away from the feet towards the head. They're at about minus 60 or so. But the one thing you need to consider as an alternative explanation for a marked left axis deviation is if there's an absence of signals heading towards the inferior wall. Let's just say, for example, and I think this will become very clear in a moment. Let's just say, for example, this patient has a dead inferior wall, that they've had an inferior wall MI. What's going to happen is the signals are not going to head towards the feet at all because there's no active endocardium there. There's no myocardium to depolarize. And so most of your QRS complex signals, most of your ventricular activation is going to be heading upwards in this direction. And so having an inferior MI gives you a left axis deviation. But as I explained in the next section on ischemia and infarction, if you have an absence of electrical signals going towards a particular location in the heart, then what you'll get on the cardiogram is a Q wave. A Q wave indicates absence of electrical signals in that anatomical region. But that's not what's happening in an anterior hemiblock. There are signals that are coming from that area. And so what you get, instead of a Q wave in the inferior leads, they are negative, but what you get is a little R wave. So the inferior leads exhibit a small R wave, but they're predominantly negative because of the fact that the axis is way up here at minus 60. So when you read the books and they tell you that you should have an RS in lead 3, what is that telling you? It means you have a little R wave, indicating that you do not have an inferior infarction, but that you have a big S wave. That's why it's a capital S. The big S wave is simply an indication that the inferior leads are negative because the axis is going towards the head, and that's because you have this left axis deviation of minus 60 degrees or better. Well, the other criteria that people talk about is the fact that there's this QR in lead 1. Well, in lead 1, where does the Q wave come from normally? You should know this by now because we talked about this in several other videos. In lead 1, that little Q wave comes from septal depolarization. So that negative deflection at the beginning of the QRS complex in lead 1 comes from the fact that the septum is depolarizing from left to right because of this purple here, the septal branch of the left bundle branch system. So you get left to right activation here. Well, you want to see that septal R wave in an anterior hemiblock because you want to know that the septal branch is working and that you don't have an incomplete left bundle branch block where you would normally lose this septal activation. So characteristically, there is a small Q wave, but a tall R because, after all, lead 1 is going to be positive because the signal is still heading in this direction. Okay, so you've got this marked left axis, and because of that marked left axis, you've got negative QRS complexes in lead 2, but you preserve the R wave there because you don't have an inferior MI. And in lead 1, you expect to see a small Q, but a tall R, mainly because we're still heading in this direction. Now, if this is very confusing, once I show you an example, it should all come together. Here's my first example of left anterior hemiblock, and it looks fairly normal initially. When you look at the forest, you can see it's a little irregular. You have some sinus arrhythmia. You have a little bit slower rates here, and then it speeds up a little bit in the middle, and then it kind of slows down a little bit towards the end. So it's just sinus arrhythmia with an average rate of somewhere around 65 or 70 beats per minute. You can see the P waves are upright in 1 and AVF, and so we'll call it a normal sinus rhythm. But when you look for the QRS axis and you look at all these leads, you notice right away that AVR seems isoelectric. Now, given that the inferior leads here are negative, and so the QRS axis is heading away from the feet, it tells you that you are at an axis of minus 60 because you are isoelectric to AVR and you are headed away from the feet. So that minus 60, immediately you should think, oh, does this patient have a left anterior hemiblock? Well, to make sure they do or they don't, look for R waves in the inferior leads. Since you see an R wave there, you know this is not an old inferior MI.
Well, to verify, you see a small Q and a tall R in lead 1.
Well, there's your diagnosis. That's all you need to know. This patient has left anterior hemiblock. Some people call it left anterior fascicular block or hemifascicular block if you really like a lot of syllables in your words. And the one thing that I do want to point out is that there's almost always a disturbance in the R wave progression in these hemiblocks. You can see in V1 there's not much of an S wave. Then you have sort of a tall R, almost looks like a transition point in V2, but then it reverses itself, and then you've got basically very small R waves all the way out to V6 with a deep persistent S wave. So the transition in the precordial leads is almost always disturbed, and I generally call it late transition due to the presence of the anterior hemiblock. If we go back to this drawing here, let me just remind you that when you look at the chest in cross-section, that what's happening in anterior hemiblock, the signals are heading away from the septum over towards the lateral wall, but the lateral wall is really posterolateral because of the way the heart lies in the chest. So you wind up missing a lot of the vectors that would normally head towards V2, V3, V4
they wind up being shifted posteriorly. And to me, that seems to be the most reasonable explanation to why you get late transition, because of shifting in the sequence of activation of the left ventricle and movement of the vectors away from the anterior precordial leads. Okay, so let's look at one more example. And this is a different patient, but it looks almost the same. And so I hate to talk about pattern recognition. I really want you guys to understand electrocardiography and the physiology that goes into it. But this is a pattern that you should recognize very quickly after a while. Again, you have a normal sinus rhythm. I'm not going to belabor that point. You've got negative QRS complexes in 2-3 and AVF. You've got a positive QRS in lead AVR now, and you should immediately think of anterior hemiblock when you see a positive QRS complex in AVR, especially with a negative P wave, because if your P waves are headed in the right direction, then you know you don't have something crazy like someone put the leads on the wrong limbs. Well, this being positive and almost as tall as lead 1, it seems the axis here is going to be somewhere on the order of, well, where would it be? If lead 1 was most isoelectric, which it isn't, that would make it minus 90. Lead AVR is clearly the most isoelectric, but it's more positive. So it's more than 60, but nowhere near 90. It's not even halfway to 90. So I would call it minus 70. Sometimes you just have to use your noodle and in your head sort of interpolate between these leads. So if you have an axis of minus 70, then you should look for R waves in the inferior leads to make sure you don't have an inferior MI. And there's a nice R wave right there. And there's a little micro R wave in 3 in AVF. It's teeny tiny, but it's there. It looks like the QRS goes up before it goes down. And again, you've got this disturbed R wave progression across the precordium with some positive forces in V1 and V2, which may be a reflection of early septal activation. But then you've got these really deeply negative QRSs in V3 through V6, consistent with late transition. And that's because of the disturbance of the sequence of activation of the left ventricle. Keep in mind, the QRS complex is narrow, so it's not a bundle branch block. It's an anterior hemiblock. In the next video, we'll talk about posterior hemiblocks and the notion that people can have block in the septal branch of the left bundle that can result in loss of the septal activation that we'd normally see. Well, I hope this video clarified somewhat confusing diagnosis of left anterior hemiblock. This is Dr. Nick for the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this third video is going to cover left posterior hemiblock and what some have referred to as septal hemiblock. Well, just remember that the left bundle divides into 3 branches, one that seems to feed the septum, a second branch that crosses over the left ventricular outflow tract and stimulates the anterolateral region, that's the anterior hemifascicle, and the largest branch of the 3 is the left posterior hemifascicle that runs close to the posterior medial papillary muscle and depolarizes this portion of the left ventricular endocardium. I believe the left posterior hemifascicle, being the largest of the 3, is the least likely to fail in isolation. I searched through hundreds of cardiograms, and it's very rare to find an isolated left posterior hemiblock. And we see it much less than a left anterior hemiblock. But you can imagine what happens in a left posterior hemiblock is that the septum and the anterior wall depolarize rapidly. And then the signal has to make its way to the posteroseptal region slightly later than it should, but not late enough to cause the QRS to become excessively delayed. So the QRS duration, again, is less than 120 milliseconds. But what happened is the main vector of depolarization shifts to the right. And so you get a right axis deviation of greater than or equal to 120 milliseconds. In our axis circle, if lead 1 is looking straight across, AVR would be 30 degrees above the horizontal, and the perpendicular to that would be plus 90 and then another 30, so that's plus 120. Like anterior hemiblock, we're in this half of the circle, and AVR winds up being positive, but with this rightward axis, the inferior leads are going to be upright. In this view, what happens is the electrical signal spreads from the septum to the anterior wall initially, but the large area of inferior myocardium depolarizes in this direction, so you have a shift in the axis towards the patient's right.
So the inferior leads are going to be upright, but lead 1 is going to be negative. Now, what other things can cause a right axis shift like this? Well, just like in anterior hemiblock, where you want to rule out an inferior wall MI as being a cause of a leftward shift, and thus you have to look for a small R wave in the inferior leads. By the same token, what you need to rule out is the presence of a lateral wall MI. In lateral wall MI, there's an absence of electrical signals here, so the axis shifts away from that region. But then in the lateral leads, like lead 1, what you'll get is a QS pattern, with the Q wave indicating absence of signals in the lateral leads consistent with an old lateral MI. But that's not what we have here. So I'm going to erase that. We have a healthy lateral wall. And so what you get is a small R wave in lead 1. But most of the vector is going away from lead 1. It's rightward. So the S wave is much deeper than the R wave. That's the reason why the textbooks tell you that you should see a small R and a big S in lead 1. Now you know why. The other finding you expect to see in lead 3 is a large R wave because you have this right axis deviation. Remember, lead 3 is essentially pointing in this direction. So you have a tall R wave in lead 3, but you should still see a small Q wave in lead 3. And the reason is that the initial deflection is going to be away from the feet towards the anterolateral region because the anterior hemifascicle is going to depolarize first. So initially it goes away from the feet and then it turns around and heads towards the right side. So you have this kind of circular movement in the electrical axis showing up as a small negative deflection, but then a tall R wave because most of the signal is headed towards the right. I'll show you an example, the one decent one that I found, and here it is. This is tachycardia at 110 beats per minute. If you look for P waves, you'll find that there's something that's going up in lead 1, but it seems to be going down in lead 3, and it turns out that this is actually a slow atrial flutter with 2-to-1 conduction. You can see a second flutter wave present in front of the QRS in these 3 beats, but it's not present here. And the second flutter wave is superimposed on the T wave here. So you have 2-to-1 conduction for the most part, but this is a difficult tracing from the standpoint of reading the arrhythmia. What I'm mostly concerned is pointing out the fact that AVR here is positive, and lead 3 has a tall R wave. Now you don't see the little tiny Q because the flutter wave is superimposed on it, so I wouldn't make too much of that, but you do have this tall R in lead 3. More importantly, you have a small R and a deep S wave here in lead 1. If this was a lateral MI, you would expect to see a QS pattern in the lateral leads, but no, you see an R wave, but deeply negative QRS, indicating that the axis is going away from the lateral leads in the rightward direction. And since AVR looks to be a little bit more positive than it is negative, the axis here is about plus 130. I'll show you examples of left posterior hemiblock in combination with a right bundle branch block. That's referred to as bifascicular block in the next video. But for now, this is the best example of an isolated left posterior hemiblock that I could find. Now, the last subject I want to touch on in this video is the concept of a septal hemifascicular block. It's been reported that the septal branch has the shortest refractory period, meaning that it tends to conduct when the other branches don't. If you remember, the action potential of a Purkinje fiber is rather long, and for a certain period of time after this fires, there's a certain refractory period where the tissue is inexcitable, and at some point that refractory period finally expires, and the cell becomes excitable again somewhere at the bottom of this downstroke. Now, if one hemifascicle has a shorter refractory period than the other, it recovers faster, and the hemifascicle, perhaps that has a longer refractory period, will fail to conduct at a particular rate where one fascicle has recovered and the other has not. So if the heart rate happens to be this far apart, then you're going to wind up with block in one of the fascicles, most likely the anterior hemifascicle, much less likely the posterior hemifascicle. But what do you think the ECG would look like if the septal branch was affected. What part of the ECG represents septal depolarization? Certainly we know that in V1 the small R wave represents septal depolarization, and in the lateral leads, one in AVL, you should have a small Q wave that represents septal depolarization. So in a septal vesicular block, you lose those small signals that arise from the septum. And V1 winds up having a QS pattern, and the lateral leads lose that little Q wave. Now, I frequently see ECGs where V1 and V2 have no R waves at all, and a lot of people are tempted to call that an old septal MI. But then when you do an echocardiogram on the patient, they have normal left ventricular function, so why is this septal activation missing? Well, I'm going to show you a cardiogram here, which is a patient in atrial fibrillation. And you can see the fibrillatory waves here on the baseline. And the heart rate is rather erratic, and in fact, you have a couple of very wide QRS beats here in V1 that are classic for a left bundle branch block pattern. The other beats, however, are narrow, and if you look at the rate, the coupling interval between this left bundle beat and the previous beat is quite short, and you have a long interval preceding it. You should be able to recognize this as Ashman's phenomenon. I touched on this briefly in the video on aberrant conduction, and I'll go more into it in the advanced course. But notice that the second beat is not quite as wide. So it's almost like you have an incomplete left bundle branch block pattern in the second beat, as if part of the left bundle had recovered. Now, if you look carefully, some of these beats have little R waves in V1 and V2, but some do not. And when you look at lead 1, following this long pause, there's a beautiful Q wave, but with a shorter interval, you lose the Q wave. Then this interval is a little bit longer, the Q wave comes back, and then this interval is shorter still, and the Q wave all but disappears. And this is the best example I can find of what people have termed a septal hemiblock. Most people don't think of the septal branch when they're looking for hemiblocks. And I was tempted to leave this for the advanced course, but I figured I would mention it here just to complete the discussion on hemifascicular blocks. In the next video, I'm going to go into bifascicular blocks in detail so you can recognize those easily on a cardiogram. Until then, this is Dr. Nick for the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the last video in this section, and it's on bifascicular block. Now, the name, I think, speaks for itself, bi meaning two, and that just means that two major branches of the conduction system are diseased, and the electrical signal is only going down one. For the most part, what we're talking about is a right bundle branch block plus block in either the left anterior or the left posterior hemifascicle. So what you'll see is right bundle branch block with your typical V1 look, either RSR prime like this or RSR prime like this. And because you have a marked axis deviation, AVR will appear to be upright. Then what you do is look at lead 1. And if lead 1 is predominantly upright, with a wide S wave because of the right bundle branch block, but you have a QR pattern with a small q and a tall R, that tells you that the axis is a left axis deviation. That tells you that you have left anterior hemiblock, right? Because it's positive in AVR, so that means it's greater than minus 60, but it's upright in lead 1, so that means it's up here. Then we have bifascicular block, meaning right bundle branch block, left anterior hemiblock. On the other hand, if lead 1 is predominantly negative, of course it's going to be wide because there's a bundle branch block. Because it's predominantly negative, then that means it's in this half of the circle. That means with a positive AVR that we're talking about a marked right axis deviation of plus 120 or greater. And that tells you that you have bifascicular block with a right bundle and a left posterior hemiblock. Of course, to verify with the left anterior hemiblock, the inferior leads are going to be predominantly negative because you'll have a small R and a big S that goes along with the left anterior hemiblock. Whereas in the left posterior hemiblock, since it's headed towards the feet, you'll see predominantly positive deflections in the inferior leads. So if none of this makes any sense, once you see some examples, I think it'll become clear. So here's the first example of bifascicular block. And the first thing that you should recognize is it's, of course, a regular rhythm with upright P waves in 1 and AVF. And the rate's about 68 beats per minute, so it is a normal sinus rhythm. But when you look at the axis in the frontal leads, you'll see that AVR is positive. And when you examine the precordial leads,
you see a typical RSR prime in V1 and V2, consistent with a right bundle branch block. Well, when you have right bundle branch block plus a bizarre axis like this, then you should right off the bat consider bifascicular block. Now, how do you rule it out? Examine the QRS complexes, especially in lead 1. So here you have a little tiny Q wave and a tall R, so that tells you that this is a left anterior hemiblock, and as you would expect, the inferior leads are negative because the axis is headed up this way. You also want to make sure that you have R waves in the inferior leads to make sure that you do not have an inferior wall myocardial infarction. Now, we don't want that because that would keep us from making the diagnosis of an anterior hemiblock. So you want to make sure you don't have inferior Q waves. So you have nice R's there. You have a little tiny Q wave and one in AVL. So you've got the criteria for the anterior hemiblock and the right bundle branch block. So that's the bifascicular block that you're looking for. So it's a matter of having both components and ruling out other lookalikes, like an inferior MI. Now notice something else. You've got this kind of bizarre R-wave progression in the anterior precordial leads. You have a little tiny Q in V2 with a very tall R here, but then the R kind of shrinks down. The R actually gets smaller, and then you have a very large S wave, bigger than the R wave. So it's not uncommon to see these really bizarre R wave progressions in the anterior precordial leads. In fact, I often have to call late transition with this anterior hemiblock because they often go hand in hand. Here's my next example. We see a regular rhythm with upright P waves in 1 and AVF. The rate's just about 75 beats per minute, so we're talking a normal sinus rhythm. And when you look at the axis, you can see that AVR is markedly positive. And in fact, the most isoelectric lead looks like lead 1. Well, if lead 1 was most isoelectric and you had a positive AVR, then the axis would actually be minus 90, but I think this is more positive than it is isoelectric. So the axis is probably about minus 75 or minus 80. When you look at V1, you see that it is markedly upright in V1 and V2 with notching that looks like an RSR prime. It doesn't look as wide as the last tracing, but if you measure the duration, it's about 140 milliseconds. You also have a wide negative S wave in V6. So the criteria for a right bundle branch block are present. And looking at one being positive, and you have a small R and a tall S, so you don't have an inferior infarction, that gives you the diagnosis of a left anterior fascicular block or left anterior hemiblock. And so with the right bundle branch block, you know that you have bifascicular block. It's a pretty easy diagnosis to make. Again, you have this bizarre R-wave progression across the precordium with little tiny Q waves in V1 and V2, and poor R-wave progression across the precordium with deep persistent S waves consistent with late transition. It's a very common finding with hemiblocks. So let's go on to our next tracing. You see a heart rate of about 80 beats per minute. You see upright P waves in 1 in AVF. The PR is on the shorter side. It's about 140 milliseconds. And the QRS is clearly wide. It's probably about 160 to 180 milliseconds in duration. When you look at V1 and V2, you see an RSR prime, and so you can make the diagnosis of a right bundle branch block pattern. And just like before, AVR is upright, so that gives us a bizarre axis. But now you see that lead 1 is actually negative, and 2, 3, and AVF are positive. Which is the most isoelectric? It looks like lead 2 may be more isoelectric than AVR, but it's probably in between them somehow. So, if lead 2 is most isoelectric, and clearly we're talking about a vector that's heading towards the feet because it's markedly positive in 3 and AVF, that means it would have to be isoelectric in this direction. That would make the axis, if this is plus 90 and another 60, that would be plus 150. If AVR is most isoelectric, that's headed in this direction, so you're talking about an axis of plus 120. In this case, the axis, I think, is in between the two. We'll call it plus 135. But you do have a nice R wave in lead 1, and so we're not dealing with a lateral myocardial infarction, and we have a typical small Q and tall R in lead 3. So taken together with the right bundle branch block, we have bifascicular block with a right bundle branch block plus a left posterior hemiblock. So it's really going by the numbers. You see a wide QRS, you recognize a right bundle branch block, you see a bizarre axis, and then you calculate where the axis is. It has to be in the bottom half of the circle because it's positive in the inferior leads. It meets the criteria for posterior hemiblock. You've ruled out other things that can give you right axis. including a lateral MI. In this case, you see a very tall R wave in V2 and V3, and it remains tall. So what you have is early transition, which is also very common in hemiblocks. You can either see early or late transition, just because the sequence of activation of the left ventricle is thrown off. So all in all, bifascicular block, which confuses a lot of people, is fairly easy to diagnose, as you can see. So overall, bifascicular block, which confused a lot of people in the past, is really pretty easy to diagnose, as long as you understand what you're looking for. Now, there is a concept of trifascicular block, and I want to just mention this now, but this is a whole nother section that I'm going to cover in the advanced course. Trifascicular block suggests that all three hemifascicles are affected, and you diagnose this by finding the addition of a first-degree AV block together with the bifascicular block. So if you have this combination, many cardiologists would read possible trifascicular block, but then again, maybe not. And this is kind of an advanced concept. You need to know something about His bundle studies, and I'm planning to have a complete discussion of this in the advanced course. So if you're curious, you can check out the advanced course and understand why we consider this diagnosis under these circumstances. But for now, remember that this is a diagnosis that we make if the first-degree AV block is also present in the setting of either right bundle branch block and left posterior hemiblock or right bundle branch block left anterior hemiblock. Well, now that we've completed this section, we're going to look at the changes in the cardiogram with ischemic heart disease, including diagnosing infarctions and ischemia. In the end of the intermediate course, we'll discuss other ST abnormalities and miscellaneous topics that you should know about when trying to read a 12-lead cardiogram. Well, for now, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey, this is Dr. Nick with the Ecg Academy, starting a new section on coronary artery disease and its effects on the ECG. This video is going to talk about coronary artery anatomy and physiology to give you a sense of why the ECG changes the way it does. Well, this is a picture of some serious plumbing here, and my interventional partners, I call them plumbers. And I'm proud to say that I'm an electrician. But anyway, what we're going to do is review the coronary artery anatomy, which vessels supply which part of the heart, and what happens to the cardiac conduction system and the ECG when things go wrong with the plumbing. What I have here is an animation that I put together. It's a three-dimensional representation of the heart and the coronary arteries that we can sort of turn around a little bit. And what you guys need to do is go back to the basics section and watch the video on the three-dimensional anatomy of the heart. Because I take a heart model and I turn it around and give you a sense of where everything is on the outside and the inside of the heart. So this will just be a review. Remember, the aorta comes off of the left ventricle, and just above the aortic valve, the main coronary arteries come off. You've got the left main coronary, which runs to the left side of the pulmonary artery here. This is the right ventricle, and this is the left ventricle. The left main splits into two large vessels, one that runs down the front of the heart and one that runs along the side of the heart. So the front one is called the left anterior descending coronary artery, and it runs in the groove between the left ventricle and the right ventricle. It runs in this groove, and in between, of course, the two ventricles is the septum. So it sends these branches down into the septum. They're called septal perforators, and it runs usually down to the apex. The left anterior descending gives rise to branches that feed the lateral wall and the anterolateral wall of the left ventricle, and these branches are known as diagonal branches. The other branch that comes off the left main coronary artery is known as the circumflex coronary, and it runs in the groove between the left atrium and the left ventricle. So that's the left atrioventricular groove, parallel to the large vein that drains the heart, known as the coronary sinus. The circumflex wraps around to the back of the heart, where in most people it just sort of comes to an end. But it does give rise to large branches that feed the anterolateral region and the lateral wall of the left ventricle, and these branches are known as obtuse marginal branches. Now let's look at the right coronary artery. The right coronary artery comes off of the aorta and runs between the right atrium and the right ventricle in the right AV groove, giving rise to small branches known as acute marginal branches. The right coronary artery usually turns around to the back of the heart, and then in most patients turns around and becomes the posterior descending coronary artery, which you can't see in this view, but it runs on the posterior wall in the posterior interventricular groove. Now, I said most people. That's because about 80% of patients are known as right dominant because the right coronary artery is the one that gives rise to the posterior descending. About 15% of patients are left dominant, meaning instead of the circumflex coming to an end in the back of the heart, it turns around and becomes the posterior descending, a very large branch that feeds the posterior wall and the inferior wall of the left ventricle. So in summary, the left anterior descending, or LAD, feeds the anterior and the anterolateral wall. It can definitely feed the lateral part of the left ventricle. The circumflex feeds the lateral and sometimes the infero-posterior wall in patients who are left dominant. And the right coronary branch supplies the right ventricle, and in most patients, the posterior wall and the inferior wall. Now let's take a look at this other cartoon again. This is showing the left anterior descending, or LAD, as we call it, down the front of the heart in the groove between the right ventricle and the left ventricle. The right coronary artery runs along the right AV groove and then turns around and becomes the posterior descending. So if we slice the heart in cross-section, what we see here is the LAD, that's the left anterior descending coronary artery, and back here in the posterior AV groove, we see the posterior descending artery, or PDA. This is usually a branch off the right coronary, but sometimes the circumflex. Next to these arteries, of course, we see veins, and these veins drain the myocardium and bring it all back to the coronary sinus, which then empties into the right atrium. Now, all these branches of the coronaries are located on the outside of the heart. They're epicardial in nature. The heart is interesting. It's the only organ where the arterial system runs on the outside of the organ and sends branches into the organ from the outside. Every other organ, for example, the kidney, has a large artery which then branches and gives rise to a circulation that starts in the center and moves outward. But in the heart, the branches are on the outside and they branch inward. The reason is when the heart contracts, it generates a lot of pressure inside, and it would impede the flow of blood because the blood would have to move through this muscle and a chamber that's under high pressure. So this way, blood flows much more easily. But when the heart is contracting, remember that the pressure inside the heart is quite high, and that does tend to impede the flow of blood. So blood generally only flows in diastole while the heart is relaxing, and the blood flows from the epicardium to the endocardium in this direction, because that's where the blood vessels are, and it's only the very inside layer of cells that gets some oxygen from the blood pool itself. Now, the next thing I have to talk about is the electrical system. Remember that the Purkinje fibers run on the endocardium, on the inside, and there are different branches, of course, the different hemifascicles that supply different parts of the left ventricle, and the right ventricle as well is supplied by Purkinje fibers that run off the right bundle branch. But that means that the electrical signal arises from the endocardium and travels to the epicardium. So it runs in this direction from the inside to the outside. Now, some people have asked me, why is it that the QRS complex, which represents depolarization, and that's where sodium ions rush into the cell and the cell becomes more positive, is followed by a T wave that occurs during repolarization. But repolarization is happening because potassium ions are rushing out of the cell. So it's really like the opposite electrical event in the cells. But on the surface, on the ECG, this depolarization and repolarization both occur in the same direction. I mean, if repolarization was an opposite electrical event, why isn't it going in the other direction? Well, that's a great question, and it seems that we can explain it by pointing out that the electrical characteristics of the endocardial cells is slightly different than the electrical characteristics of the epicardial cells. If we take a look at the action potential of an endocardial cell, it actually is fairly prolonged. Now remember that electrical signals have to travel from the endocardium to the epicardium. So if we look at an epicardial cell, it's going to depolarize slightly later. However, epicardial cells have a shorter action potential duration, and they recover sooner. And so the epicardium recovers first, and repolarization occurs in a sequence that goes from epicardium to endocardium. You get it? So this reversal of the direction of flow of the electrical signal, where depolarization is going from endo to epi, and repolarization goes from epi to endo, that's what seems to be responsible
for the fact that T waves go in the same direction as the QRS complex in most leads. Well, now this section is about coronary artery disease. And so what happens to a coronary artery when atherosclerosis occurs? You have branches of these coronary arteries that are supplying different parts of the epicardium and the myocardium. And when we have a poor balance of lipids in our blood because of genetic reasons or dietary reasons, you can then see plaque laid down on the inside of these arterial walls, plaque that restricts the opening of the artery, what we call the lumen. And with the lumen getting more narrow, the flow of blood becomes restricted. Now, these plaques are usually laden with cholesterol, nasty, cheesy stuff. And under the right circumstances, you can get a lot of inflammation that occurs there. Now, as the walls of the artery become more and more narrow and the flow of blood becomes more and more restricted, see when it gets to about 80% or maybe 90%, then when the person is at rest, they may not have any symptoms. But if they try to do some exercise and the heart needs more oxygen to meet its metabolic requirements, then the blood that's trying to get through this narrow opening may not be able to flow fast enough to supply all the oxygen that the heart needs. And then what happens is part of the heart muscle, whichever part is being supplied by this blocked artery, suffers from a lack of oxygen. And most of the time it results in a chest pain or discomfort or pressure that we refer to as angina. Exertional angina pains can be the first sign of a blocked artery, but it's usually a pretty narrow blockage that causes angina. A 50 or 60% lesion that only partially occludes the opening usually will not cause any symptoms, except under one circumstance. And that is, if that plaque were to rupture, if you have injury of that plaque, a lot of that cheesy cholesterol material gets extruded into the opening of the artery, and it's very irritating. And then what happens are these little tiny fragments of cells floating around in the bloodstream called platelets adhere to this injured part of the vessel. And once platelets adhere, they undergo a chemical reaction that causes more platelets to clump together. And once those platelets clump together, they can form a plug. And that plug corks off the artery altogether, and then that part of the heart gets no blood. And that's what causes a heart attack or acute myocardial infarction or MI. So if the LAD gets corked off right here, this part of the heart suffers from a lack of oxygen, and that's what causes a heart attack. Now, the effects of these coronary events show up on the electrocardiogram in very characteristic ways, and that's going to be the subject of the rest of these videos in this section. So until then, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy. In this video, we're going to discuss what happens to your ECG when coronary events occur. There are basically two kinds of coronary events that I discussed in the first video in this section. One is where the blood is having a hard time getting through a blockage in an artery where you have a narrowed area because of a plaque and the blood is squeezing through and there's restriction of blood flow. And this results in a reduced oxygen delivery to the heart muscle cells. This situation is known as ischemia, and it results from hypoxia or reduced oxygen delivery to the muscle cells. The other situation that we're going to talk about occurs when a plaque ruptures and you have accumulation of a platelet plug that results in complete occlusion of this artery and cessation of blood flow to part of the myocardium. And this is known as infarction. The physiologic differences, if I could use this cross-section, have to do with how much of the wall thickness is affected by the process. Here we have the left anterior descending coronary artery. And let's say that this LAD had a severe blockage and the patient was experiencing ischemia. What that means is the amount of blood that's flowing out of the branches of this LAD is reduced. Now, since the blood travels from epicardium to endocardium, the area of the heart that suffers the most is this region here, what we call the subendocardial layers of the heart muscles. And so ischemia is sometimes referred to as subendocardial ischemia. It just describes the fact that some of the blood is getting through and some of the heart muscle is receiving oxygen, but the layers furthest from the supply are now hypoxic. In contrast, let's say if you had a total occlusion of the PDA, the posterior descending coronary artery. At that point, no blood flows to that region of the heart, and the heart becomes very unhappy. In fact, what you get is transmural ischemia, or full thickness effects, where the entire region of the heart is not getting any blood and suffers from hypoxia. So this is known as transmural ischemia, and if it goes on for any length of time, it results in permanent damage or myocardial infarction, affectionately known as MI, in that region of the heart. So we have ischemia, which only affects part of the wall thickness, and we have infarction. Now we'll also discuss what happens if this blockage opens up some reason and the infarction does not extend through the whole thickness of the heart. Let's start with ischemia. Now with ischemia, without getting too complicated, what you generally see is ST segment depression in the anatomical region that's affected by the ischemia. Now it doesn't always correlate precisely. Let's say you had a subtotal occlusion of the right coronary artery, and so the underside of the heart is now ischemic. Now, under normal circumstances, 2-3 and AVF will tend to be upright, and the ST segment is isoelectric with the baseline. So if you draw a line from one baseline interval between the T wave and the next P wave, that you'll see the ST segment is about at that level. When ischemia occurs, what you generally see is ST segment depression, and you can measure that amount of depression in millimeters. So in lead 3, for example, what you'll see is this ST segment depression, and that can be a sign of ischemia. If you see it in the inferior leads, it points to the inferior wall. You can also see it in the lateral leads or the anterior leads. Now let's just review which leads point to which areas of the heart. So the inferior leads we know are 2, 3, and AVF. The anterior leads V1 through V4, with V1 and V2 mostly septal. V3, V4 mainly anterior wall, and then 1 AVL, V5, and V6 pointing more towards the lateral wall. Now what about the posterior wall? Well, we don't have leads over the posterior wall, so what we generally look for are opposite changes in the anterior leads. And we'll talk about this in a subsequent video. Well, now, where exactly do you measure this ST segment? Because ST segments can be depressed, but they can have a changing slope. You can have ST segments that slope down. You can have ST depression that's horizontal. And you can also have ST depression that's upsloping. So downsloping, horizontal, and upsloping all have different meanings. Downsloping is usually more serious. Horizontal is moderately serious, and upsloping tends to have the least significance. When we're trying to measure how much ST segment depression there is, we generally measure the ST segment at 80 milliseconds after the J point. So the J point is where the QRS complex ends and the ST segment starts. 80 milliseconds would mean 2 small boxes. So at this point, you would measure it compared with the baseline, which is the interval that follows the T wave. Now, when the heart rate is very fast, for example, if someone's on a treadmill and exercising, the P's and the T's tend to run into each other, and the baseline becomes obscured. So in that case, we do have to use the PR segment as the baseline. But under normal circumstances, we try to use the segment that follows the T wave and precedes the next P. So those are the changes that occur with ischemia. Now, what happens if an artery becomes occluded, like the LAD, and you wind up with an area of the heart that has transmural ischemia? In other words, total wall-to-wall absence of oxygen and blood flow. You have hypoxia that runs the full thickness of the heart muscle. Well, in that case, what you see in infarction is ST segment elevation. So ST segment elevation is the hallmark of an acute MI. In the case of the LAD, if you were to look at V2, we generally see a pattern like this where the STs rise above the baseline. And in extensive infarctions, the changes can be so dramatic that they're referred to as tombstones, because it kind of looks like it. Now, when the artery first gets occluded, you may not see that ST segment elevation. You may just simply see tall T waves or other kinds of nonspecific changes. But as time goes on, you get that clear ST segment elevation, and it may persist for days. What happens eventually is that this infarcted region becomes electrically silent, and over the course of several days, the ST segments come down. But what happens is, whatever electrical activity was in this region heading towards this anterior wall was really represented by this R wave. And with an infarction, what happens is the R wave is lost, and you wind up with a Q wave. Eventually, what happens is the ST segments become isoelectric with healing, but you're left with a QS pattern, which tells you that there are now no electrical signals in that region, and all the electrical activity is headed away from that anterior wall. So what we could modify this and say that acute infarction results in ST elevation, but after some time, what happens is you develop Q waves. So the presence of Q waves indicates absence of electrical signals in that area, and that suggests an old myocardial infarction, or maybe a recent. It's hard to tell how long ago it happened, and that's why a lot of people use the term indeterminate age or age unknown to indicate that the Q waves are present, but we don't really know how long ago the infarction occurred. One last event that I want to talk about is when you have total occlusion of an artery and you have transmural ischemia that occurs, but then the occlusion either spontaneously opens up and that area is reperfused, or if someone has an acute intervention like a cardiac catheterization and a balloon angioplasty and then a stent is placed to reopen that blockage. So you can have this arterial occlusion with a whole bunch of plaque in here, and then you can have a platelet plug. And what the interventional cardiologist will do is pass a very thin wire through that occlusion, known as a guide wire. And it's usually soft so they can often get through this. And then over that guide wire, they'll pass a catheter that has a balloon on it. And this balloon is fairly narrow, but it gets filled with liquid, and it causes the balloon to expand and essentially smush the plaque out of the way. And then when the balloon is emptied, the balloon gets smaller, and you're left with a nice opening there that restores the blood flow. Now, often the balloon is removed and a stent is inserted. A stent is essentially a thin tube that's made of very fine wires, sort of in a crisscross, and you can actually see through it if you see one. So that's slid in and deployed, and it winds up basically holding this area open, acting like a scaffold to maintain patency of this artery. But what happens to the myocardium, let's say if the LAD gets occluded, is that you initially have transmural ischemia with ST segment elevation. But when blood is restored, the acute ischemia is relieved. But what can happen is you may be left with infarction of the region that was furthest away from the artery. And so this is known as non-transmural myocardial infarction, otherwise known as a subendocardial MI, and it has a very characteristic look of the ECG. So if you started out with an ECG that looks like this, during the acute infarction, you'll have ST segment elevation. But if blood flow is restored, then what happens is the R wave remains, but your T wave becomes inverted. It seems that the normal reversal of electrical activation, what normally happens is that Purkinje fibers depolarize the endocardium first, and depolarization occurs from endocardium to epicardium, and then repolarization occurs in the opposite direction, from epicardium to endocardium. But in the region where you have damage of the subendocardial layer, where the Purkinje fibers are located, well, this region does not behave normally. You lose that reversal of electrical events, and that's why the T wave winds up going in the opposite direction to the QRS complex. In the next video, I'll show you examples of coronary events, including ischemia and infarction, so you'll get some practice diagnosing these events in different anatomical regions. Until then, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and boy, doesn't that look good. Yum, yum. Well, that's actually someone's aorta. Yes, this is known as pizza pie aorta, because what you see here are all these cheesy-looking plaques, atheromatous plaques along the wall of the aorta. Some of them appear to be ulcerated. It's really gross looking. And this is what happens when you don't take care of yourself. So when these kinds of changes affect the insides of your coronary arteries, well, then you got trouble. Well, this video is going to review some of the changes that we see with coronary artery disease, including ischemia and infarction. And we reviewed what to look for, so now we're going to get to some tracings, actually. This is a tracing of a fellow who came to the emergency room with acute chest pain. It occurred while he was exercising, and he's still having some pain. And what you see is a normal sinus rhythm with upright P waves in 1 and AVF. This looks like an atrial premature beat. The axis looks to be isoelectric in AVL, which makes it about plus 60 degrees. But when you turn to the precordial leads, you see this ST segment depression. And it's not artifact, it's consistent in every lead. And I can see that there's at least 2 to 2.5 millimeter horizontal ST segment depression in V2 through V6. And also, you have a little bit, about 1 millimeter in lead 1, and not quite so much in AVL, maybe 0.5 millimeter in AVL. It's not exactly diffuse. In fact, the STs are isoelectric in the inferior leads, and what you see is ST elevation in AVR. Now, you can't have an acute infarction in AVR, so this is simply a reciprocal change, and we would call this ischemic changes in the anterolateral leads. This is almost always due to significant coronary artery disease, probably in the LAD distribution, because it's affecting the anterolateral region, and doing a cardiac catheterization would likely find severe atherosclerosis in that region of the coronary artery tree. But just notice the appearance of this ischemic change. The J point is depressed. That means the point where the ST segment takes off, and it's quite horizontal. And then the T wave remains upright, and you certainly don't see Q waves. You've got these very large, normal-looking R waves marching across the precordium. So this is not transmural ischemia. This is not myocardial infarction. This is subendocardial ischemia due to a mismatch in supply and demand. Usually this means that the myocardium is demanding more than the coronaries can supply. Recognizing ST depression as diagnostic of ischemia is really what you need to learn, is really what you need to get out of this tracing. Okay, now here's the next tracing. And at first glance, when you look at V1 and V2, you see downsloping ST depression. And you think, oh boy, this looks like another case of ischemia. But V3 here looks like only a little bit of horizontal ST depression. V4 is isoelectric, but V5, now you have a little ST elevation. And V6, there's a lot of ST elevation. And if you glance, if you follow my cursor, follow the bouncing ball over to the inferior leads, 2, 3, and AVF, look at that. You've got essentially tombstones. This is marked ST segment elevation with only a little tiny bit of R waves here. And this is a picture consistent with an acute inferior wall myocardial infarction. There may even be some lateral involvement here because V5 and V6 have ST elevation as well. So we could be talking about a very large right coronary artery that wraps around and gives off a posterior descending that would affect the inferior wall and a posterolateral branch that would maybe pick off part of the lateral wall. You don't see ST elevation in 1 and AVL. In fact, you see ST depression in 1 AVL, and you see the ST depression in V1 through V3. Well, which takes precedence, depression or elevation? The answer is elevation is always more important than depression. The elevation is what you should be looking at, and the depression is more of an electrical phenomenon that we refer to as reciprocal changes. It doesn't mean that the lateral wall or the anterior wall is truly ischemic. These are just sort of like the flipped over electrical gradients of the inferior infarction that we're seeing from the other side of the heart. In other words, if we take the heart in cross-section, and you've got the left ventricular cavity here and the right ventricular cavity here, and you have a big old inferior infarction that's going on. Well, the anterior leads, V1 and V2, are basically opposite that infarction that's going on. And so here, you'll record ST elevation, but from the other side of the heart, what you'll record is ST depression. And it's kind of like just the inverse, or the electrical flipping of the phenomena that are going on in the heart muscle itself. This is a very important point because in a true posterior myocardial infarction, the posterior wall of the left ventricle really doesn't have any ECG leads over it. And sometimes with a posterior MI, all you'll see are these reciprocal changes that occur in V1 and V2. In fact, a posterior MI is usually diagnosed with a tall R and then ST segment depression in V1 and V2. If you were to take this, what I'm going to do with my fancy Photoshop, I'm going to take this and I'm going to flip it over. Oh my God, isn't that cool? What you're seeing there is a Q wave and ST segment elevation. So in a posterior MI, you'll actually see changes limited to V1 and V2, but the changes specifically will be a tall R wave and then ST depression. I'll try to find some examples for you for the next video, which is basically going to be practice identifying evidence of ischemia and infarction. Okay, well, let's go on to the next tracing. All right, here we have a regular rhythm. It looks like a normal sinus rhythm at about 90 beats per minute. And when you examine the limb leads, you see it's most isoelectric in lead 2. And so where the axis would be is about -30. So you have a left axis deviation, and the question is why? Well, if you notice, the QRS complex in the inferior leads has a Q wave. A very large Q wave, in fact. The initial deflection is downward in 2-3 and AVF. Together with the left axis deviation, this is consistent with an inferior myocardial infarction of indeterminate age. So we don't know how long ago it happened. It could have been a month, it could have been 20 years. But the idea is there's a distinct lack of electrical signals going towards the inferior wall, and that's why there's no R wave here. Everything is going away from the feet. That's why you've got negative deflections here. So these Q waves allow you to diagnose an old inferior MI or inferior MI of indeterminate age. When you examine the anterior leads, you see that the R wave progression is not that good. You got little tiny Rs in V1, V2, and V3. It's only about 1 millimeter in V3, but it does grow fairly sizable in V4, so this may be a reflection of lead positioning. There's also a little bit of an interventricular conduction delay. The QRS complex is only about 100 milliseconds wide, but it almost looks like you have an RSR prime. So a lot of people would call this a right IVCD or a nonspecific IVCD, but then again, some cardiologists would just ignore it. It's likely just a reflection of the damage of the Purkinje system in the inferior wall. Now, what we do see are T-wave inversions in V1 through V6. Actually, V6 is more biphasic. But these T-waves clearly don't go in the same direction as the QRS complex the way they should. But they're not terribly deep, and there's no ST changes. And so most people would consider this nonspecific T-wave abnormalities. We're going to cover more of these kinds of nonspecific T-wave abnormalities in the next section of this intermediate level. Here's a next ECG, and when you look at the rhythm strip down here, you see there's a little bit of irregularity to it. You can see upright Ps in 1 and AVF, and you see a very consistent P wave and a rather flat T wave in lead 2 in this rhythm strip. So notice that it's a very consistent flattened T wave. Now this beat came early. The QRS complex looks the same as all the others, but there does appear to be a P wave and it came early. So this is an atrial premature beat. APB, APC, PAC, whatever you want to call it. What about this beat here? I want you to see these P's come on time. The on-time P wave would land here. This is another PAC, which is the same as this. I don't want to confuse you guys. But this one happens to be inverted, whereas this one is more upright and bifid. So the patient is having multifocal PACs. What about this wide beat here? Well, here's a tricky one, and I should use this as a chalk talk, because if you look in front of this wide complex beat, you'll actually see something that looks exactly like this. So you have this PAC, and it looks like there's a PAC, a P wave, that's a little inverted. It comes quite early, right after the QRS complex is finished, which is quite a bit earlier than this one here. If you look at this interval, it's quite a bit longer than this interval. So this has to be a PAC with aberrancy. I bet you guys didn't expect that one. So you got a wide QRS complex because of aberrant conduction of this PAC. If you hadn't looked at these T waves, you wouldn't have noticed that little P there. And if that surprises you, you better go back to the basic course and practice more with premature beats and aberrant conduction. But you know what? That's not what we put this strip up here for. It's this. What you see here in V2 and V3, a significant ST segment elevation, and it goes out to V4, V5, and V6 you've got a little bit left. So it starts at V2 with about 1.5 millimeters, and it gets as tall as about 3 to 4 millimeters here. You also have a distinct lack of R waves. There's an R here in V1, and then they disappear. So the septum is not being affected. In fact, you have nice septal Q waves in the lateral leads. So this is an acute anterior MI, not anteroseptal. If you notice, the ST elevation is highest in V2 through V4, which is more the anterior wall. So notice that lack of the R wave is a real giveaway. A lot of times when you'll see just subtle ST elevation, that's one of the discriminators. If you have, let's say, in V2, just a little bit of ST segment elevation, usually the tall R wave means that it's not an acute infarction, but rather something else. And we'll talk about other things that cause ST elevation in the next section. But this looks pretty good for an acute anterior MI. Okay, one last tracing, and this one looks pretty quiet by comparison. What you have here is a normal sinus rhythm at about 75 beats a minute. You might say, oh, look at that. Maybe there are like Q waves over here. But I think you might be able to find a little tiny R wave in this lead, and certainly the Q wave in AVF is not significant. What do we consider a significant Q wave? It has to be at least 40 milliseconds wide, or be at least 1/3 as high as the entire QRS complex. So even if you thought this little tiny R wave was noise, and you thought that this was a Q wave, you only have 1 out of 3. And the criteria for diagnosing an acute inferior MI has to be 2 of 3 leads. And for the most part, you can't diagnose ischemia or infarction based on just one lead. You really kind of have to see 2 contiguous leads in the same anatomical distribution to say that ischemia and infarction are present. What I do see here is a distinct lack of R waves all the way out to V5. In fact, I would say that there's a QS pattern in V1 and V2 and the barest hint of an R wave in V3. This is clearly an abnormal R wave distribution, and there's even some residual ST elevation here. But at the very least, I would call this anteroseptal MI. Some people would consider this ST elevation as possibly recent. It could be just indeterminate age, but there is some suggestion that persistent ST elevation in the anterior leads might lead you to think that there could be an aneurysm. An aneurysm, if you're looking at the left ventricle during diastole, if you're looking at it from the side, if this is the anterior wall and this is the inferior wall, normally when the ventricle contracts, you have thickening of the muscle and you have all the walls coming together at once. What happens in an infarction is that you get thinning of the muscle of the anterior wall where it's been damaged and scarred. And then with contraction, and you can see this either on echo or on a left ventriculogram in a cath, the inferior wall comes in and thickens, but the anterior wall stays the same. That's known as akinesis. If it moves but moves in a reduced fashion, we call it hypokinesis. Kinesis meaning movement. Well, an aneurysm is a deformity that occurs during diastole. So basically it's an outpouching of the anterior wall because the scarring and the thinning was so bad that the anterior wall is literally stretched out like a balloon on a tire. So there's a diastolic deformity, and usually this doesn't move at all. It's completely akinetic. So the inferior wall may contract a little bit, but the anterior wall stays the same. So that's what an aneurysm would look like, and this persistent ST elevation can be a sign of an aneurysm. In the next video, I'm going to go over some more examples of ischemia and infarction to give you some more practice. But until then, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the Ecg Academy, and this is the last video in this section about ECG abnormalities due to ischemia and infarction. So I'm going to introduce a couple of new topics, but this is mostly for practice, just to give you a few more examples of what I was talking about in terms of assessing ST abnormalities and diagnosing acute infarctions and those that we often call age indeterminate because we're not sure how old they are. So this was an old gal who came to the emergency room complaining of chest pain. And when you start to look at the ECG, you see this significant ST segment depression in lead 1. It's horizontal, if not actually a little bit downsloping. about 2 millimeters here. And if you look at AVL, 1 and AVL being the lateral leads, you see it's even more pronounced here, downsloping and almost 3 millimeters. And you can think to yourself, well, maybe there's some ischemia going on. And if you kind of glance over to V2, you see the same kind of thing, that ST segment depression. But when you examine the inferior leads, here's where the key is. You have ST elevation in the inferior leads, and right away what you have to do is consider these ST depressions as reciprocal. So it's not the ST depression that you're worried about, it's the elevation. So this is an acute inferior MI. In fact, it's probably been going on for some time because if you notice, the patient's already lost her R waves. There are already Q waves in the inferior leads indicating that there's no activity in that region, and so this has probably been going on for a few hours. Which coronary artery would affect the inferior wall? Most of the time it's the right coronary artery, because in about 80% of patients the right coronary artery is known as dominant, and that means it comes off the aorta, runs around the right AV groove, and then reaches the back of the heart where it turns around and becomes the posterior descending. So the right coronary artery in most cases feeds the posterior and the inferior wall. So whenever you see an inferior infarction, you have to wonder if it may be affecting the posterior wall as well. Well, how do we diagnose posterior infarctions? Well, we look at V1, 2, and 3. Now, in V1, there appears to be an RSR prime, so there's a right bundle branch block going on. The QRS duration is just about 120 milliseconds, so we have to call this a complete right bundle branch block. But when we look at V2, look what's happened. If you want to describe it, it's a tall R wave, and then there's this downsloping ST depression, and then a kind of a biphasic T. But remember what we said about the posterior wall. We don't have any ECG leads over the posterior wall, so all we're going to see are reciprocal changes. Reciprocal meaning kind of backwards, like we're looking at it from the opposite side of the heart. If I were to take this signal and just flip it over, now what does it look like? It looks identical to that, doesn't it? Well, that's because the same process is going on in the posterior wall. We just can't see it because we don't have an ECG lead over that area. But we see the reciprocal changes that are virtually identical to what's going on in the inferior wall. Let me undo a couple of those and go back to where we were. So this configuration of a tall R wave and ST segment depression under these circumstances is consistent with an acute posterior wall MI. So we have an infero-posterior MI because of a very large dominant right coronary artery occlusion. Notice that the anterior wall doesn't have any ST abnormalities because the problem is mostly confined to the infraposterior region. So perhaps it's unlikely that this was due to a circumflex problem. So remember, the circumflex runs in the left AV groove and goes around to the back of the heart. But in only about 10% of patients does it become the posterior descending and feed the infraposterior wall. Okay, well, this very same patient, a few hours later, I'm going to show you what happens to the cardiogram. Okay, here it is. Now, if you notice, the ST segments here have come down. They're not as elevated as they were, and so the myocardial infarction is evolving. These are evolving changes of an acute MI. You've got big-time Q waves in the inferior leads, all three of them. So the inferior wall essentially is gone. The STs are coming down, and you have this asymmetric T inversion, which eventually what happens to these patients is you're left with a Q wave, but the T eventually winds up coming upright. That may take a few days or weeks before that happens. But this is sort of considered evolving changes of an acute MI. But look what's happened to V1 and V2. You still have that right bundle branch block, and that hasn't changed. But if you notice that V2, the R wave has grown. This is the R prime, so that's the right ventricle. We don't just ignore that for the time being. But you have an R wave that sort of grew, and you have an early transition. And if you notice, there's really no S wave. The S wave, which normally V2 would have a significant S wave, but this S wave is gone. It's missing. The S wave there kind of represents the posterior wall. Whenever you see a tall R in V1 and V2, you have to think about an old posterior MI. So the first thing you do is you look in to see if there was an old inferior MI. If you see an old inferior MI and a tall R wave in V1 and V2, then you can call an infraposterior MI age indeterminate. In this case, it's recent. Here's another patient, and it's just an example of inferior Q waves. So when you look in 2-3 and AVF, you can see Qs in all 3 leads. You see these sort of asymmetric inverted T waves as well. So those go along with the old infarction. But here in V1 and V2, you still have a decent S wave, and you have a nice S wave in V3. So you have a little tiny R. The R gets bigger, but the S is still larger in V2, so the transition point is normal at V3. So this patient does not have an old posterior MI, simply just an old inferior MI, or age indeterminate, if you want to be precise about it. Now, I found this ECG, and it's kind of interesting because it has ST abnormalities that you'll find in all the ECG textbooks. Kind of crazy to read because there is an arrhythmic going on here. You actually have sinus beats going on here with some sinus arrhythmia, and then here there's an atrial premature beat. So there's a PAC here, and then a couple more sinus beats. And if you look over here in V1, the lead changes right here, and it makes it look like a P wave. But I think there's another beat that looks just like it, and I think that's the tail end of the T wave right here. So there does not appear to be a P wave in front of either of these beats, and so I would call this a ventricular premature contraction, PVC, with a right bundle branch block configuration. So that would mean it's most likely coming from the left ventricle. But now you can see V1 and V2, V3, and this is what I wanted to show you, is that what you have is ST segment elevation and this really bizarre, huge biphasic T wave in the interior leads here, going all the way out to V5, where the T wave is still inverted in V5. Well, in a person with chest pain and this kind of ST segment abnormality, this is actually known as Wellens syndrome. It was described by Dr. Hein Wellens in 1982, and it highly correlates with occlusion of the left anterior descending coronary artery. So if someone presents with chest pain and they have this kind of ECG change, you might want to call one of your invasive cardiology partners to see if they think the patient should go to the cath lab, because this is a fairly specific sign of acute anterior ischemia due to severe LAD disease. Well, this could be the same patient, except after the occlusion is opened. So now if your LAD opens up and gets reperfused, either spontaneously or due to thrombolytic therapy like TPA, or because of an acute intervention like a stent or an angioplasty, now what happens is you wind up with these very large T-wave inversions across the precordial leads, but you have nice R waves that persist. So transmural infarction did not occur, but your repolarization is disturbed, likely because of subendocardial infarction. So the subendocardium gets damaged, and that affects the sequence of depolarization, because now the Purkinje fibers perhaps don't work in this region, and that region has to depolarize from areas that are coming in from the side. So now that normal endocardial to epicardial sequence of activation is disturbed, and you don't get the reversal of flow with repolarization. And so now the T waves get disturbed, and this is a sign of a non-transmural or subendocardial MI. Now, in the absence of chest pain, if the clinical circumstances are somewhat different, these symmetrical T-wave abnormalities may wind up being associated with normal left ventricular function. And so it's a bit of a nonspecific abnormality. It doesn't definitely correlate with coronary artery disease. These symmetric T waves can sometimes be nonspecific. So just keep that in mind, that a lot of times interpreting these ECG changes depends a lot on where the patient's been and what their prior ECG looks like. It's conceivable that these changes have been there for years. And I have had many patients who came to me with this kind of ECG abnormality, and you do echocardiography and stress testing, and as far as we can tell, their ventricle is normal. And so in some cases, it's just purely an electrical disturbance in repolarization. Well, this is my last tracing in this section, and it's simply an example of a patient who has a sinus rhythm with a little bit of left atrial abnormality that you can see here, the biphasic P wave, predominantly negative, with that's greater than 1 box high and greater than 1 box wide. But if you notice, there's a QS pattern in V1, V2, and only the tiniest little bit of an R wave in V3. There's hardly any R in V4 as well. So you have a lack of anterior septal forces. Notice there's no septal Q wave in 1 AVL, and there's no septal Q wave in V5 and V6 either. So you have loss of septal and anterior forces here, and so you'd call this an anteroseptal MI of indeterminate age. Age indeterminate. Every ECG system that you use has different terminology. Sometimes you have to write it in, sometimes you type it on a computer, and a lot of times they have drop-down menus or some other means of making it easy for you to use these abbreviations. But the age indeterminate simply means we don't know when it happened. It could have been a month ago, it could have been 20 years ago. But the absence of electrical vectors in this area tells us that there's no activity in the anteroseptal wall. Now, could this be lead positioning? Could this be simply late transition? Well, it's not late transition because you don't have these persistent S waves. If it was late transition, then you'd have these persistent S waves in V5 and V6 where the transition point didn't come out until V6 maybe. So I would not call late transition on this one. Could it be lead misplacement? Possibly, but unlikely because of the absence of the septal forces even in the lateral leads. So I think this is pretty convincing. Ultimately, the electrocardiogram is not the most specific tool we have, and you always have to consider that you may make a diagnosis and it may turn out to not be true, but what you're trying to do is give an accurate reading, because if you're watching these videos, you want to be an ECG expert. In the next section, we're going to talk about other changes in the ST segment and the T wave that are not due to ischemia or infarction. They're not due to coronary artery disease, but due to other problems as well, and you should be able to recognize them. Until then, this is Dr. Nick with the Ecg Academy. Thanks for watching.
Hi, this is Dr. Nick with the Ecg Academy, and we're starting a new section which is kind of a mix, a hodgepodge of different problems all causing STT abnormalities. In the last section, we talked about the effect of hypoxia, namely ischemia and infarction, but there are lots of other things that can affect ST segments and T waves, and we'll try to get through them one by one to give you a better sense of what to look for. I thought I would start with something called secondary T wave abnormalities, because it's a bit easier to understand and somewhat easier to diagnose as well. Well, think of it this way. When the heart depolarizes and you have a QRS complex, repolarization, and as I mentioned in the previous videos, the reason that the T wave goes in the same direction as the QRS complex, even though it represents the opposite electrical event, is because if you take the left ventricle in cross-section, the Purkinje fibers are on the endocardium, so depolarization occurs from endocardium to epicardium. But because the epicardial cells have a shorter action potential, duration, compared with the endocardial cells, which tend to have a longer action potential duration, then the epicardium recovers sooner, and the sequence of repolarization goes in the opposite direction from epicardium to endocardium. So your T wave goes in the same direction as your QRS complex under most circumstances. Well, what happens is when the normal activation of the left ventricle is thrown off, when the normal depolarization is affected by some other myocardial problem or some electrical problem, then it's going to affect repolarization. So think of secondary T-wave abnormalities as being due to abnormalities in the QRS complex. So there's secondary to QRS complex abnormalities, and all of these conditions affect the QRS complex and affect the sequence of activation, and they give rise to ST wave changes in most cases. In most cases, we call these ST wave changes discordant because for the most part, the ST and T wave deviation or change goes in the opposite direction from the QRS complex. So in other words, if the QRS is up, the STTs go down. And conversely, if the QRS complex is mostly down, then the ST wave abnormalities are going to be deviated upward. Well, let's look at some examples of this. Now, here's a patient who's actually in a sinus tachycardia. Most of the aorta are intervals. Here's one that's close to a heavy line, but there's a little bit of sinus arrhythmia, and the heart rate is about 130 beats per minute. Now, there's some irregularities as well. If you map this out, you see actually this QRS complex comes early, and it's a premature atrial contraction. The P wave, in fact,
looks a little bit different than the normal sinus P wave. But you begin to notice when you examine these QRS complexes carefully that if this is the baseline, which would be between the T wave and the following P wave, that you can see that the STs do appear to deviate quite a bit in various leads. But when we look at our precordial leads, we can see the reason why. Look at this huge voltage in V6. And if you add up the R wave in V5 plus the S wave in V1, it more than adds up to the 35 millimeters that you need to diagnose LVH. And the ST wave abnormalities that we see in the lateral precordial leads are pretty classic for a strain pattern. And that is downsloping ST depression and then somewhat inverted T wave that eventually resolves. And if you look at V1, the STs, in fact, are elevated slightly. So this is an example of LVH with strain. We saw this before in the video dealing with LVH, but I just use this as an example in that you can see diffuse STT wave abnormalities that you might consider as maybe ischemia or some other reason, but in this case we have to consider them secondary STT wave abnormalities due to the presence of LVH. Well, aside from LVH, you can see secondary STT abnormalities in anything that disturbs the sequence of depolarization of the heart, including interventricular conduction disturbances like bundle branch blocks. So here's an example of a sinus rhythm, and the patient has a left bundle branch block. You can see there's distinct notching in 1 and AVL. You have this QS pattern in V1 all the way out to V4. So it's a pretty classic left bundle branch block pattern. See the notching in V6 as well with an RSR prime. But when you look at the ST segments, you'll see that they're really deviated quite a bit. Here in 1 and AVL, you've got about 1 millimeter to 1.5 millimeters of ST depression, and in V1 and V2, you've got about 2 or 3 millimeters of ST elevation. But again, these are discordant, meaning they go in the opposite direction to the QRS complex. These are discordant secondary ST wave abnormalities because of the left bundle branch block. So these are secondary. Someone reading this ECG wouldn't even mention them. I mean, you would just call it a sinus rhythm with a left bundle branch block and leave it at that. There's some left atrial abnormality as well. You would not mention the STT abnormalities. This is just part and parcel of the left bundle. Now you'll see the same thing in a right bundle branch block. But here I'm showing you an example. You've got, again, normal sinus rhythm. And when you look at V1, you can see that there's a sort of a QR pattern. But with V2, you do have this sort of fragmented, you could call it RSR prime. But what gives it away is the wide S wave in 1 and AVL. Although the QRS complex is not particularly wide, it's still only about maybe 110 milliseconds. So if you were reading this ECG, you would call this an incomplete right bundle branch block because it's less than 120 milliseconds, but it has the characteristics with a late anterior force in V1 and V2 and this wide S wave in the lateral leads indicating that there are signals moving away from the lateral lead towards the right ventricle at the tail end of the QRS complex. But what I wanted you to notice in this tracing is that there's a little bit of ST segment depression in lead 2. You've got inverted T waves and a little ST depression and T wave inversion in AVF. And then you also have this sort of bizarre ST wave abnormalities. They're not really serious. I mean, it's only about 1 millimeter. A lot of people would look at this and wonder if this was ischemia. But in the setting of this IVCD, with these ST changes would be acceptable because they are discordant. They go in the opposite direction from the QRS complex. They're only 1 millimeter, and it would be reasonable to just consider them entirely due to the IVCD. The last example I'm going to point out is due to a different kind of disturbance in the sequence of depolarization. And if you notice in this tracing, the PR interval is very short. The PR segment is virtually non-existent. The QRS complex starts with a slurred upstroke, so you should be able to recognize this as a delta wave. The PR here, you can see, is very, very short. This is a typical example of pre-excitation or Wolff-Parkinson-White syndrome. But if you notice, you've got ST depression here, and it's quite marked in the inferior leads, and you have ST segment elevation here in the anterior leads. Notice again they're discordant. They go in the opposite direction from the QRS complex. And as I've mentioned in previous videos, when you have an accessory pathway that allows for the pre-excitation of the ventricle, here's your AV node, and you have an accessory pathway down here someplace. Accessory pathways do not delay the signal like the AV node does, and as a result, part of the ventricle depolarizes early. That's why it's called pre-excitation. Now, that disturbance in the normal activation of the left ventricle is what results in the characteristic abnormality of the QRS complex, that is widening. So you get a wide QRS, and you get the delta wave. The fact that the QRS starts early because of antigrade conduction down the accessory pathway is why your PR is short. And the reason WPW looks the way it is normally you would have a PR segment in a very rapid upstroke of the QRS complex. In WPW, because you have that pre-excited area in the ventricle, your P wave, of course, occurs on time, but the QRS starts early, and the QRS widens at the expense of the PR interval. So the PR interval shortens because the QRS is starting early. Get it? Because it's being pre-excited. Now, because the sequence of depolarization is thrown off, well then, the sequence of repolarization is thrown off, and you get those secondary T-wave abnormalities. You wouldn't call these, when you were interpreting the cardiogram, you would just call it pre-excitation. The secondary T-wave abnormalities are part of that characteristic QRS. Okay then, in the next video, we'll talk about primary ST wave abnormalities, which unfortunately are often nonspecific and leads to this huge wastebasket diagnosis of nonspecific ST wave abnormalities. But until then, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey, this is Dr. Nick with the Ecg Academy, and this is a second video in our section on STT abnormalities other than ischemia. Well, I threw this ECG up there just as a sort of a teaser, because when you begin to look at this cardiogram, you can see that it's simply a normal sinus rhythm at about 60 beats per minute. And when you begin to look at the QRS complexes, you notice something. You say, normally, the T wave should go in the same direction as the QRS complex, but here you've got a situation where the T wave is inverted. When is it abnormal to have an inverted T wave? The definition of an inverted T wave is one that's upside down but greater than 1 millimeter in amplitude. If it's less than 1 millimeter up or down from the baseline, then we consider it a flat T wave. So this one here, although it looks like it may be pointing down, is still considered flat. Well, when is it abnormal to be inverted? It turns out that it's common for AVL and for lead 3 to have inversion of the T wave, where the T wave goes in the opposite direction from the QRS complex. It's also common for V1 and sometimes V2 to have a negative T wave. So if you see that, it's considered a normal variant. It's also normal to have less than 1 millimeter of ST segment depression, as well as elevation, with one caveat. If you see ST depression of maybe 1 to 2 millimeters, make sure you look for elevation, because sometimes that can be a reciprocal change. And if you see ST elevation in 2 contiguous leads, except of course for AVR, because ST elevation in AVR doesn't mean anything. But if you were to see even 1 millimeter ST segment elevation in the inferior leads in the context of ST depression in the lateral leads, you really have to think about an acute MI, as we saw in some of the videos in the previous section. But this video is about nonspecific ST wave abnormalities and the kinds of things that will cause non-ischemic T wave problems. Now, these are considered primary because they are not due to abnormalities in the QRS complex. So the QRS essentially is normal. You don't have LVH or an IVCD like it did in the last video, but instead you have primary T-wave abnormalities. So here's a list of things that can cause nonspecific ST wave abnormalities. And you can go through the list. I'm not going to spend a lot of time on every single one, but clearly there may be normal ECGs that have nonspecific changes, and they're simply normal variants. For example, mild T-wave inversion in V1 through V4 in a relatively young person, especially if the T-wave gets less inverted as you get past V3 and V4, and that can be what's sometimes known as persistent juvenile T-waves. Of course, conduction abnormalities can lead to secondary changes. but you may have just changes in the axis that can lead to T waves looking not quite right. We're going to talk about electrolyte abnormalities in the last section of the intermediate course. But as I said, there's a whole host of medical and systemic conditions such as drugs or adrenaline, or especially CNS problems like stroke or intracerebral hemorrhage that can lead to very bizarre T-wave abnormalities. And I'm not going to show you examples of each and every one of these, but I will give you a sense of what's considered nonspecific. And it's the nonspecific thing that's people use it quite often, and it doesn't mean normal necessarily. It can be abnormal, but it doesn't tell you exactly what's wrong. And sometimes it's the degree of abnormality that will cause you to label one ECG as being borderline and another ECG as being abnormal. Here's an example of a nonspecific ST abnormality that's very commonly seen during sinus tachycardia. Here are the rates above 100. It's about 125 beats per minute or so. And you have upright P's in 1 and AVF, so you have a sinus tach. But notice the inferior leads. There's a bit of ST depression compared with the baseline, which should be the TP interval. Now, sometimes if the rate gets fast enough, you won't even be able to see that baseline, and you have to take the PR interval as being the baseline. But even compare with the PR interval, there's about 1 millimeter of ST segment depression and maybe 0.5 millimeter in the other two inferior leads. Well, some people say that there's an effect of ST depression due to atrial repolarization. And the fact is, this degree of ST depression in the setting of a sinus tachycardia is considered nonspecific ST abnormality. It doesn't mean there's ischemia. In fact, this ECG came from a fairly young person, someone in their 30s. There is some poor R-wave progression here, but you get a nice healthy R-wave by the time you get to V4, and it may be a reflection of lead positioning. And in fact, it's not uncommon to see perfectly normal left ventricular function when you have an ECG like this. So it's nonspecific, meaning you don't always find a physical reason for these ST abnormalities. It's really just purely an electrical disturbance. Well, another purely electrical disturbance is drug-induced, and that's what's known as digoxin effect. And you'll see this in most of the textbooks, although we don't use digoxin too much anymore. But the digoxin effect is described as an ST segment depression, but it's a coved, downsloping ST depression that has a very rapid resolution up to a T wave. And so it kind of looks like a reverse check mark. Here's what a check mark looks like. A reverse check mark looks like that. So it's got this kind of like downsloping and then rapid recovery. This is a pretty good example of it. Now, granted, this person has voltage criteria for LVH, and so some of the exacerbation of this ST wave abnormality may in fact be due to strain. But you see this ST segment abnormality and the inverted T waves, the reverse check mark, so to speak, in almost all the leads, which is not characteristic of LVH. That's why I thought this was a good example of digoxin effect. You can see it everywhere. To be honest with you, I try not to call digoxin effect unless I know for sure the patient is actually taking digoxin. It's a little embarrassing to actually put it on the cardiogram as part of the official reading and then find out they're not even on it. And so it is considered a nonspecific ST abnormality, but it's fairly characteristic, and you should look out for it because it's pretty easy to recognize. Here's another example of a nonspecific ST abnormality. Again, we have a sinus rhythm at around 65 or 68 beats per minute. We have kind of a generous R wave here. That's considered minimal voltage criteria for LVH. But the STs look okay in the lateral leads. You don't see those typical strain changes. What you do see are T waves that are flat across the entire precordium. And in fact, they're sort of kind of biphasic with maybe a secondary upright deflection that some people would call a very small U wave. And then they're a little inverted in V4, and then they flatten out again in V5 and V6. There's no real ST segment abnormalities, so these are purely T waves that just don't look right. It's not exactly in an anatomical distribution. You see it anterolaterally, but you also see it inferiorly as well. So these are considered just diffuse, nonspecific T-wave abnormalities. We consider this just a borderline change, and it's really quite common. Here's another example of nonspecific ST and T wave abnormalities. Here you do have about a half a millimeter. Here you do have about a half a millimeter of ST segment depression. The T wave is fairly flat, and you see this in the lateral leads. The T's are kind of flat in V3 as well, and they're flat in the inferior leads as well. So it's diffuse T wave flattening. They're flat in 1 and AVL as well, with a little bit of ST depression in V5 and V6, but it's less than a millimeter. So this is a great example of nonspecific ST and T wave abnormalities. This is probably the most common ECG diagnosis that we use on a daily basis. And here's one more example where the STs they're a little funny looking, but they're very unimpressive. It's barely a half a millimeter. It's kind of inferolateral. The key is to look and see if these change. If you have serial electrocardiograms and these ST segments appear to wax and wane, they get worse and then they get better, that's much more specific for ischemic changes. But this in and of itself really doesn't tell us much. The last example of nonspecific T-wave abnormalities I want to show you is this one, and I see this fairly often in the ICU, especially in the neuro ICU. When you look at this cardiogram, it really does start to look very bizarre. The first thing you should notice are these huge T-waves, and they're not only inverted, but they're extremely large, and often they're distributed diffusely. In this particular cardiogram, you've got the inferior leads and some of the midlateral leads that are affected. But the QT interval is also very long. Here it exceeds 400 milliseconds at a fairly rapid rate. So if you look at the midpoint between the R to Rs, you can see the QT is much longer than halfway. So you've got these huge, bizarre, symmetrically inverted T waves, a long QT interval. And this is a patient who's had a stroke. In fact, you can sometimes see these T-wave abnormalities in the very early stages of either a stroke, and you can also see it in someone who's had either an intracranial hemorrhage or has some other reason for it, increased intracranial pressure. So the brain has influenced the electrical characteristics of the heart and has resulted in these T-waves that some investigators have referred to as neurogenic T-waves. There's such a variety of ST wave abnormalities that it's really hard to show each and every one. It's much more important to recognize the ones that are more likely due to ischemia and infarction, and when you see something that's nonspecific, at least be familiar with that list of causes so you can begin to think about ruling some of them out. In the next video, we're going to specifically talk about pericarditis and early repolarization, two conditions that result in diffuse ST segment elevation, but they're obviously quite different, and they each have their own clinical implications. Until then, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick with the last video in this section of ST and T-wave abnormalities. This video is about pericarditis, and another very common abnormality that we see on electrocardiograms is early repolarization. Well, this actually is an MRI image of a person's heart. This here being the chest wall in the front, and you have the diaphragm down here. And here's the heart hanging in the chest. And what you can see is actually the left ventricle, its chamber. The left atrium is over here. And here's the edge of the muscle, and there's some fat around the heart. But this dark line, I'm going to paint it, but then I'm going to get rid of it. Right around here is the space around the heart. I'll get rid of that. That dark line right there is known as the pericardial space. There's a very thin membrane that surrounds the heart, that's attached to the heart, known as the visceral pericardium. Peri meaning around, and cardium, of course, meaning heart. So this membrane wraps around the heart, and then at the edges it sort of reflects, and then there's a second layer that's on the outside of the heart. So it's like a double membrane with a space in between. The heart itself would be inside here, attached to the visceral pericardium, and the outer layer is known as the parietal pericardium. Now that's not terribly important, but the idea is that there's this space, and the space is lined with cells, and the cells generate a certain amount of fluid. It's a very sort of slippery fluid that allows the heart to beat with very little physical friction. But what can happen is that the lining of this pericardial space can become inflamed. It can become inflamed because of a viral infection, or because of bacterial problems or because of inflammatory processes. But for whatever reason, what often happens is that you have an accumulation of extra fluid in this space. And that fluid is sometimes very irritating, and it can cause a fair amount of chest pain that can sometimes be quite severe. Characteristically, this chest pain is worse when you take a deep breath, and it also tends to be worse lying down and better with sitting up. It hurts to cough because essentially anything that causes the heart to jiggle around inside the chest is going to create a pain sensation. Well, on the electrocardiogram, there's a very specific finding, and that is ST segment elevation, but it's not confined to one lead. You see diffuse ST segment elevation all throughout the cardiogram, and sometimes it can be quite severe when you can have 2 or 3 millimeter ST segment elevation. But you see it in virtually every lead except AVR. AVR, you usually see depression. So let me show you some examples of that. Here's a patient who presented with pleuritic chest pain, which means it hurts more to take a deep breath. And as you can see, you've got ST segment elevation up off the PR interval in all 3 inferior leads, and you also see it anteriorly in V1 all the way out through V6. So you have this ST segment elevation. It's about 2 millimeters on average. But in AVR, look at that, the ST is depressed. Notice the T waves are not terribly huge or peaked or anything, and there are no pathologic Q waves to be seen, but a lot of times this diagnosis is made from the clinical history, and that is chest pain. So if you have chest pain, particularly if it's pleuritic, and you have an ECG that looks like this with diffuse ST segment elevation and depression in AVR, the other thing that we commonly see, in fact, is PR segment depression. So if you compare the PR segment with the baseline, see here the baseline is about 2 small boxes above, and the PR segment seems to be just a little below that. So PR segment depression is often seen. You have depression of the ST and AVR, and this is a typical example of pericarditis. I'll show you another example. This is a different patient, and the distribution of the ST segment elevation is a little bit different. Here you have elevation V2 through V6. That's very apparent. Some people would consider this J-point elevation along with the STs, so the QRS is actually ending right up here, quite high above the baseline. Same thing here. You see it also in the lateral leads, 1 in AVL, and to a lesser degree in the inferior leads. Lead 2 clearly has it, 3 in AVF not so much. The ST segment's depressed in AVR, but again this was a patient with a chest pain kind of syndrome, but it wasn't typical angina pains. It was pleuritic and it was positional. Sometimes these patients can have low-grade fevers, or they can be suffering from other symptoms of a viral illness. But this is just pericarditis, and you should be able to recognize it. Now, there's one other condition that causes diffuse ST segment and J-point elevation, but it's considered a normal variant by most people, and it's called early repolarization. Here's an example. Now, with early repolarization, it's almost like there are positive going forces in the very beginning part of the ST segment that cause the STs to be elevated, but in a very concave fashion. So it's a very curved ST segment that you see with an elevated J point. You also see T waves that are rather peaked. They're relatively tall. And if you notice that the heart rate here is considerably slower than we saw with pericarditis. And that's because in pericarditis, people are having pain and their heart rates on average tend to be a little bit faster. Now with pericarditis, you usually see ST segment elevation across the precordium, and then you'll often see it in most of the limb leads, but not necessarily all of them. And these are often young patients. It's frequently seen in black patients. And in the absence of other symptoms, it's considered to be a normal variant. Here's one more example that we would consider early repolarization. You can see the ST segments are elevated up off the baseline. They're very smooth and concave, and sort of like the J point starts up very high and drops down and then comes back up again to form the T wave. Here again you have elevated J points, ST segment elevation. In this case, it looks like there's a RSR prime consistent with a right IVCD, but you don't have an S wave in the lateral leads. So it's not an incomplete right bundle branch block, but this is actually a common residual in young patients. This sort of ST segment elevation is present inferiorly as well as laterally. And again, you've got these relatively large T waves that are more common in early repolarization than they are in acute pericarditis. So when you see diffuse ST segment elevation, think pericarditis, but in an asymptomatic patient, the appearance of early repolarization is very similar. Early repolarization is often considered a normal variant, and if you only have maybe 1 or perhaps at most 2 millimeter ST segment elevation in a young patient, a lot of cardiologists, a lot of ECG readers will just ignore it and consider it normal. As I said, there are a lot of subtle changes in the STs and the T waves that are often hard to categorize and place neatly into discrete little cubby holes. A lot of it is just experience and having a sense of what's normal and what's not. Don't forget that you can subscribe to the Chalk Talks, and I do go over quite a bit of this ST segment abnormalities in the 12 leads that I present. So that's another way for you to get some practice in distinguishing what's normal from abnormal, and if it is abnormal, what the most likely diagnosis is. Of course, if you have a clinical experience taking care of patients either in a hospital or on an ambulance rig or in your private office, experience is really the best teacher. But in the meantime, that's the end of this section, and we're almost at the end of the intermediate course. I'm going to just clean up with a couple of miscellaneous topics in the last section. Armed with this information, you should be able to tackle most 12-lead electrocardiograms. There may be some rare conditions that I will try to get to in the advanced course, but the advanced course is more for people to delve deeper into the different mechanisms of arrhythmias, to understand them better. For example, looking at SVT and being able to distinguish between 4 or 5 different mechanisms of SVT. That's definitely a lot more challenging than what we've covered so far. And if you're up for it, I encourage you to watch some of those videos. But in the meantime, this is Dr. Nick with the Ecg Academy. Thanks for subscribing. Hi, this is Dr. Nick with the Ecg Academy, and I'm feeling mighty low. We're going to talk about low voltage in this video. In the second half, we're going to talk about what does the ECG look like if you accidentally put the leads on the wrong limbs, and even if you put a precordial lead in the wrong spot. Well, anyway, this is a laundry list of causes of low voltage, and pretty much what we're talking about is either a resistance problem, in other words, if there's something in between the heart and the skin that restricts the flow of current. So pericardial effusion would do that, a pleural effusion, obesity, or emphysema where your lungs are overinflated. Then you have either fat or fluid or air that gets in the way of the heart. So the electrical signal of the heart doesn't get to the ECG machine. Pneumothorax, again, when you have this air surrounding the heart that impedes the flow of current. So then the voltage that you measure on your cardiogram is reduced. Other things that can cause low voltage is a decrease in the voltage generation. So if you have something like a previous massive myocardial infarction or ischemic cardiomyopathy, dilated non-ischemic cardiomyopathy where healthy muscle tissue is replaced by fibrous scar tissue, or infiltrative myocardial diseases like amyloidosis and sarcoid and hemochromatosis, where you have some foreign material that's being deposited in the myocardium, then you won't be able to generate as much voltage, and instead of a nice healthy R wave, you get little R waves. Scleroderma anasarca being edema is sort of referring to this, and constrictive pericarditis, where you have a very thick fibrous shell around the heart, and that, of course, can lead to it. Well, what's your criteria? It seems to vary from one expert to another, but pretty much if the limb leads are all less than 5 millimeters, which is equal to less than 0.5 millivolts, or if the precordial leads are all less than 10 millimeters, or less than 1 millivolt, that qualifies for low voltage. Some ECGs can just be low voltage in the limb leads. Other ECGs can be read as low voltage in the precordial leads. But if you call it low voltage overall, then that implies that both of these are true. So I'll just show you a couple of examples. So here's one from my hospital, And when you look at it, you say, well, yeah, that's low voltage, man. Each of the limb leads is less than 0.5 millivolts or 5 millimeters, and each of the precordial leads is less than 10 millimeters in height. And so we would just simply call this low voltage. It's a pretty easy diagnosis to make. Just don't miss it because it occurs more often than not. In fact, there are some people who have low voltage and there's really nothing wrong with their heart. It can be a normal variant, but you should, of course, look for one of the reasons that I stated on the previous slide. Here's another example of low voltage, and this is a patient with a left bundle branch block. But if you notice, the low voltage is limited to the limb leads. Here you have each of the limb leads, 1, 2, 3, RLF, they're all less than 5 millimeters. But the precordial leads don't fit the criteria. This one's almost 20 millimeters in height, so you would call this low voltage in the limb leads, and that's a perfectly acceptable diagnosis. Okay, let's switch gears now and talk about lead misplacement. What happens if you put the lead on the wrong limb? Well, let's first remind ourselves of Einthoven's triangle, or the variant of that is the axis, the circle axis. We have the right arm, we have the left arm, and we have the left leg. In general, the right leg serves as a ground. So this was the triangle that Einthoven came up with. And so if we look at lead 1, that's from right arm to left arm, and it looks at any signals going in the horizontal direction. Now, lead 1 in general should have an upright P wave because the P wave axis is generally going to be from the high right atrium down and to the left of the patient. So the P wave axis, it should be positive in lead 1 and also positive in lead AVF. But what happens if you accidentally switch your right arm and your left arm electrodes? What if these get switched? Well, now lead 1 is going to look at everything that's going in this direction. So essentially, lead 1 is going to be reversed. You can probably take lead 1, and like I did with some other leads in the past, just flip it upside down. So what you should expect to see is an inverted P wave and a QRS that's mostly down, and a T wave that goes upside down too. But the inferior leads will look fairly normal. Now what I did in that tracing, that last tracing, is I did exactly that. I switched the left arm for the left leg, and sure enough, that's what we see, is an inverted P wave, a QRS in lead 1 that is negative. So if we were to figure out what the axis is, it's isoelectric in lead 2, which goes this way, 60 degrees above the horizontal. So if it's negative in lead 1, that would make the axis markedly rightward over here at plus 120. Well, we know that's a very bizarre axis, but it's the negative P wave that really gives you the clue. You would not expect a negative P wave in lead 1 unless the patient has something like dextrocardia. Now, what is dextrocardia is when the heart is lying on the right side of the chest, kind of reversed with the apex of the heart in this direction, and in that case, you would have a right axis deviation, and your P wave would be traveling down and to the right, and it would be negative in lead 1. But in dextrocardia, all the precordial voltage is on the right side of the chest wall, so you would not see these normal R waves in V5 and V6. They would be very, very small. You'd have like very little voltage out here. I mean, dextrocardia is not something that we see very often. But when you see a negative P wave in lead 1 and a right axis deviation with a negative QRS in lead 1, but everything else looks normal, you can pretty much say that this is lead misplacement. Well, let's look at a couple of more examples. This is a great example of a classic lead switch, and you should be able to recognize this in the future. What you see again are negative P waves in 1, but this time there's also a negative P wave in AVL. You have very, very small QRS complexes in virtually all the leads, but most importantly, lead 2 looks like a flat line. There's no QRS complexes that we can see at all in lead 2. Now this happens if someone accidentally reverses the right arm for the right leg. So if these two leads accidentally get switched, right arm for right leg, then lead 2, which normally would be from right arm to left leg, is now going to be right leg to left leg. Essentially what it's doing now is measuring the voltage difference between one leg and the other leg. And since the heart is up here, you really don't measure much voltage difference between the two legs. That's why lead 2 winds up looking virtually flat. So lead 1, which would normally be from right arm to left arm, is now going from right leg to left arm. So that makes the vector like this, and since your sinus node is usually going down, that's why the P waves are inverted here. Here's an example I found from the hospital. You can see in this case, the patient very well might have LVH. They've got a very tall R wave in most of the leads in the limb here, but if you see lead 2 has got very little signal. So this is a great example of incorrect lead placement. Here's one if you accidentally exchange your 2 limb leads for your 2 leg leads. What happens is that lead 1 is now from your right leg to your left leg, and that gives you a flat signal in lead 1. So when you see a flat signal like that, you can pretty much guarantee that your limb leads were incorrectly placed. The last thing I want to mention is that sometimes lead placement in the precordial area can be a problem as well. Remember, you're supposed to have a certain R wave progression that starts in V1 with none or very little R wave, and it gets larger and larger. Well, here what happens is the R wave in V3 is quite tall, but it gets smaller again in V4. Now, under the right circumstances, people might see a really small R wave in V4 and think that the patient has an old anterior MI. But you have to realize here that V3 has a much larger R wave, and in this case what happened was V3 and V5 got reversed. So you have this tall R wave that belongs in V5 is stuck in the middle here in V3, and it makes V4 look relatively small, as if something was wrong. But when you see this kind of abnormal R wave progression, you have to always wonder if 2 of the precordial leads were accidentally switched. Well, that's it for this video. We'll talk about other miscellaneous findings in ECGs, like electrolyte disturbances and other kinds of things, in the rest of this section. In the meantime, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hi, this is Dr. Nick, and we're going to be talking about electric light abnormalities. Wait a minute, that's not right. All right, that was a bad pun. So let's get rid of this and talk about electrolyte abnormalities. Well, there's a whole bunch of things that we can talk about: hypokalemia, hyperkalemia, hypocalcemia, but it gets really confusing when you start thinking about all these emias, and I wanted to try to put it into perspective to kind of give you a sense of what kinds of problems will lead to which ECG abnormalities. Because honestly, when you're sitting there reading an ECG, you really have to kind of go out on a limb to call an electrolyte abnormality when you're not really sure. So consider these as guidelines and then use your judgment. It's kind of like calling digoxin effect on an ST segment. It's a little embarrassing to find out that the patient's not on digoxin. So use this information wisely. So let's just try to organize things. Most of the electrolytes that cause ECG abnormalities include magnesium, calcium, and potassium. We'll talk about the easy ones first and then potassium, which is the most difficult. Well, the one thing that I've found is almost universal is that when you have low levels of these positive ions, then almost always your QT gets longer. Prolonged QT interval is common in all 3 of these conditions: hypomagnesemia, hypocalcemia, and hyperkalemia. What's kind of interesting is in hypercalcemia, what you see is if this is a normal QT interval, what happens is the ST segment gets longer, but the T wave doesn't really change much. So the QT interval in hypocalcemia prolongs only because the ST segment gets long. Conversely, in hypercalcemia, what you see is a relatively short QT interval. Interestingly, in severe hypercalcemia, you can see what are referred to as J waves or Osborn waves. J waves are these large positive deflections at the tail end of the QRS complex. It's also seen in hypothermia. Those are Osborn waves, but most of the time you don't see these. You'll just see a shortened QT interval in hypercalcemia. So in hypocalcemia, you get prolongation of the QT segment with prolonged QT interval. Hypercalcemia, you get shortening of the QT interval and sometimes J waves. Hypomagnesemia also gives you a prolonged QT interval, and here you can actually see high-grade ventricular arrhythmias, including polymorphic ventricular tachycardia known as torsade. The thing is that often hypomagnesemia occurs in the setting
of hypokalemia. And it's hard to know whether the torsade comes from the low magnesium or the low potassium. We're going to talk about low potassium at the end of this video. But certainly ventricular ectopy is common in hypomagnesemia. What's interesting is that sometimes we give magnesium oxide as a dietary supplement to people with ventricular arrhythmias because it seems to have a sort of a natural antiarrhythmic effect. So clearly magnesium is involved in the electrical system of the heart. Okay, let's spend the rest of the time dealing with potassium abnormalities because really these are most common and they're also the most complicated. Just remember that in a myocardial cell, you generally have very high potassium levels on the inside with very low sodium levels on the inside, whereas the opposite is true outside. You've got high sodium and you've got low potassium. So we'll talk briefly, remind you about the action potentials in a myocardial cell. There are these special proteins floating in the cell membrane. These are the ion channels, and there are a whole host of them. There are sodium channels, there are potassium channels. There are actually many different kinds of potassium and sodium channels. So the idea is these channels are able to open and close, and that's what gives rise to the action potential. Normally, if you measure the voltage on the inside of the cell compared with the outside of the cell using a voltmeter, you'll find that the inside of the cell has a negative charge of about minus 90 millivolts, and that's the resting membrane potential of a cardiac cell. Now, if the inside of this cell becomes more positive, usually because a neighboring cell with these cell-to-cell connections known as intercalated discs, usually sodium will rush across here as this neighboring cell fires. Once the inside of the cell reaches a certain voltage, usually about minus 80 millivolts, that's known as the threshold voltage. And with the threshold voltage, the sodium channels go from a resting state to an active state, which means they open up, basically, and sodium rushes into the cell. That allows the inside of the cell to become positive in a process known as depolarization. In a short fraction of a second, the sodium channels close and become inactive. They go from an active state to an inactive state, and that stops sodium inflow into the cell. Yes, you have a plateau phase for a little bit because of other currents that are moving back and forth, and eventually, in a time-dependent fashion, the potassium channels open up and you have rapid potassium outflow of the cell, and that allows the cell to return to the resting membrane potential. Now, the potassium flows out because of a concentration gradient. You have high potassium here inside the cell and a very low potassium outside the cell. But what do you think happens when you have more potassium outside? The concentration gradient across the cell membrane is lower. So sometimes what happens is the cell may not be able to reach its normal resting membrane potential. It may only go down to minus 85 millivolts or so under those circumstances. Now, in order for the sodium channels to go from the inactive state back to the resting state, in order for those sodium channels to reset themselves, the membrane has to reach the proper voltage. That membrane has to go back down to minus 90 millivolts because the change from inactive to resting in the sodium channels is dependent on that transmembrane potential. Now, this is getting very complicated, and I will be talking about this more in the advanced course. But if the cell does not reach its normal resting membrane potential, then some of these sodium channels do not reset themselves. And so they're not available to recruit for the next action potential. So what happens is you may get reduced sodium flow into the cell, thus attenuating the action potential the next time around, and it becomes a progressive problem. In other words, in the setting of hyperkalemia, the cell membrane becomes depolarized, and thus less sodium channels are able to respond to the next action potential. You get less of an avid depolarization, and you get slowing of conduction through the sodium-dependent tissues of the heart. So what happens in hyperkalemia? Well, the first thing that happens is you actually get these peaked T waves. Kind of everybody talks about the peak T waves of hyperkalemia. And these peak T waves are really the first sign of high potassium. But as the potassium levels begin to rise, you get a whole host of other abnormalities, including a decrease in the P wave size. In fact, they become flat and eventually disappear. You get increased PR interval and progressive widening of the QRS complex because of ineffective depolarization, reduced phase zero of the action potential. That's this upstroke because there are less sodium channels that are available to depolarize the cells. And with continued widening of the QRS complex, in fact, you can get AV block, which is probably occurring down in the His-Purkinje system, and severe bradycardia. Eventually, the QRS becomes so sluggish that it starts looking like a sine wave. And in people who are in deep, deep trouble because of hyperkalemia, the QRS becomes extremely wide and begins to look like a slow agonal rhythm. Now, here's an example of severe hyperkalemia. Where's the QRS complex? This is actually the QRS right here. So this is actually the T wave, and you have a double hump here because superimposed on the T wave, there's actually a P. So you have a very long PR interval. You have a very wide QRS complex. Look how wide that is. And you can see it especially here in V6. This QRS is over 200 milliseconds wide. The T is very peaked, and it begins to take on this sort of like sine wave appearance of the QRS complex. And it can get much worse than this as it becomes more and more bradycardic. In fact, here's an example of a very severe case of hyperkalemia, someone who is practically coding because of bradycardia and a very wide QRS complex, often associated with very low blood pressure, and you can see that you can barely see any P waves at all there. On the other hand, in hypokalemia, you can get a whole host of abnormalities that are sometimes very subtle, but you do get enlargement of the P waves, you can get prolonged PR interval, the T waves begin to flatten. So what happens initially is that you get flattening of the T waves, and then what you get is the emergence of U waves. So the T's become flat, and you get U waves that emerge. And in really severe cases, you get ST segment depression with a long PR interval and sort of a double hump with a T wave that's flat and a U wave that's very large. Now, you know what happens if you start getting QT prolongation, don't you? Now, you get complex ventricular arrhythmias like torsade. Well, that's actually more common in hypokalemia than it is any other electrolyte abnormality. So I'd like to thank my colleagues at lifeinthefastlane.com. That's where I got this ECG of a patient with severe hypokalemia. As you can see, you have this downgoing ST segment depression in most of the leads, especially here out in the lateral precordium. You have a kind of an inverted T wave. It's certainly flat in most of the leads. And then at the very end of the TU complex, you've got these large U waves. So if you were to measure the QT interval, it would seem to be very long, although many would argue that this is actually a U wave. Here's an example from my library where you have a flattish T wave, a U wave, and then this ventricular ectopy that arises from the U wave, very late coupled. And then what happens is here you have a 3-beat run of torsade that's occurring in the setting of severe hypokalemia. And finally, this is a pretty remarkable example of hypokalemia. You can see the ST segment depression here in a lot of the leads. You can see these marked U waves giving rise to runs of torsade de pointe, obviously a life-threatening arrhythmia under these circumstances. So basically, this is a summary of our discussion. Wow, what a mess, huh? I'm sorry about that. I tried to put things in perspective, but I think you'll have to go back and listen to this talk a few times. Well, if you want to see more examples of electrolyte abnormalities, check out the articles on lifeinthefastlane.com, a great website written by some critical care and emergency room docs in Australia and New Zealand. And in the meantime, this is Dr. Nick with the Ecg Academy. Thanks for watching. Hey, this is Dr. Nick with the Ecg Academy, and in this video we're going to talk about pacemakers in a little bit more detail than I did in the past, but this is really just an introduction. Pacemaker electrocardiography is a vast subject, and I'll be covering pacemaker troubleshooting in the advanced section of this course, but we could probably spend 4 hours on that alone. Anyway, this is a typical pacemaker. Actually, it's not exactly typical. Most pacemakers cannot go into an MRI, but this one actually is MRI compatible. But the pacemaker consists of the can, which we also refer to as the pulse generator. The pulse generator has a titanium shell that contains the battery and the electronics, and the top part with the pacemaker wires plug in is referred to as the header. The wires, otherwise referred to as pacemaker leads, attach to the inside of the heart muscle, either passively with little grappling hook kinds of mechanisms, but more commonly there's an active fixation mechanism that looks like a little tiny corkscrew. Now, for the most part, pacemakers are used to treat bradycardia, so either sick sinus syndrome or AV block will be an indication to use a permanent pacemaker.
So when you implant a pacemaker, you actually insert the leads into a vein. If this is your clavicle and your sternum here in the front, the two veins that drain the arm include the brachial vein and the cephalic vein. The cephalic vein actually joins up with the brachial vein. When the brachial vein passes the axillary line, it becomes the axillary vein, and it runs across the anterior chest wall and then dives under the clavicle into the chest to become the subclavian vein. As it passes under the clavicle, it's the subclavian vein. There's the jugular vein that comes down here, and internally this meets up with the jugular on the other side and the other axillary vein, and they form the superior vena cava, which then leads to the right atrium, and of course the tricuspid valve and the right ventricle, and then you have the RV outflow tract that leads to the pulmonary artery that goes out to the lungs. Okay, and that's the venous circulation. Okay, so how do we implant a pacemaker? We make an incision here, somewhere on the chest wall, and we find either the cephalic or the axillary vein, and we thread the wires into that vein. Wires can either be inserted into the right atrium or into the right ventricle. But now these wires come out the surface, and we hook them up to our pacemaker generator, and then we shove it all underneath the skin. So the pacemaker sits in a pocket underneath the skin with the excess wire coiled behind it. And it sits there, and it functions to keep the heart from getting too slow. The way it functions is it sends out tiny electrical impulses, very brief impulses, on the order of about 0.5 milliseconds. So 1/2 of 1 millisecond is equal to about 1/2000th of a second. And these little tiny impulses result in depolarization of either the atrium or the ventricle or both. Now, when you look at the electrocardiogram, a pacemaker spike often looks like a little tiny hair followed by its electrical event. Now, if it's an atrial pacemaker, that little hair, which is known as the pacemaker spike, will be followed by a P wave. And if it's a ventricular pacemaker that's operating, then you'll see a spike that's followed by a wide, bizarre-looking QRS complex. So you can have atrial spikes and you can have ventricular spikes. Now, how do we know that the spikes are effective? Well, you'll see some kind of electrical event following it. In the case of an atrial pacemaker, you should see a P wave. And in the case of a ventricular pacemaker spike, you'll see a QRS complex. Keep in mind that the QRS originates from the tip of the wire, and so it's not going to follow the normal Purkinje system. Since the wires are inserted in the right ventricle will depolarize first, and the left ventricle will depolarize through slower intramyocardial pathways. And so the QRS complex will kind of resemble a left bundle branch block pattern, as I've drawn here in V1, with a broad QRS duration, predominantly negative in V1, and a discordant T wave. And that's what you should be looking for after a pacemaker spike. Now, sometimes the pacemaker spikes are going to be huge, and sometimes you can barely see them. But we'll talk more about that in the advanced course. At any rate, let me show you what it looks like to have a pacemaker. Here's an example of a patient who has a single-chamber ventricular pacemaker. You can see a normal sinus rhythm with a first-degree AV block and a slightly widened QRS complex. But right here you see a very large pacemaker spike that lands in the middle of the PR interval, and what you notice is that the QRS becomes distorted. This initial Q wave is a little larger than the Q wave here. And so this pacemaker has begun to capture the heart. Capture is the word that we use to refer to the response of the heart muscle to the spike. Now down here you notice the pacemaker spike is occurring even earlier. So the P wave hasn't really had a chance to conduct down the AV node, and what you have here is a fully paced QRS complex. It's wide, it's bizarre, and then you've got these discordant T wave abnormalities. So that's what we have for this bottom strip. Now notice the P waves disappear. So this pacemaker is not really paying attention to the P waves. This is a single chamber ventricular pacemaker, and as you can see, single chamber ventricular pacemakers will sometimes result in ventricular pacing and you lose AV synchrony. So it will actually compete with the patient's underlying normal sinus rhythm. But this is normal pacemaker function for this kind of pacemaker. And that's one of the reasons we really don't use single chamber ventricular pacemakers in people who have an intrinsic sinus P wave, because because of this problem that you get with competition between the sinus rhythm and ventricular pacing where you lose AV synchrony. Just so that you know that this is a fusion beat because the QRS complex is partly due to normal conduction down the His-Purkinje system, but partly due to the pacemaker spike capturing part of the ventricle. And then this beat is fully paced because it looks exactly the same as all of these beats where there's no P wave to be seen. So these are fully paced, these are conducted, and this would be a fusion beat. Nowadays, the only time we recommend single-chamber ventricular pacemakers is when someone is in permanent atrial fibrillation. So here's an example of a patient who's in atrial fibrillation. You can see fibrillatory activity here in the baseline, but you also see these pacemaker spikes very prominent here in front of every QRS complex. The QRS complex is distinctly widened with discordant T-wave abnormalities, so this is pretty typical of a paced rhythm. We just simply call this electronic ventricular pacemaker or ventricular paced rhythm. But when you're reading an electrocardiogram like this, you have to try to figure out what the atrium is doing. Don't just leave it as ventricular pacing. Mention that there's underlying atrial fibrillation, but all you can say is that the AV node is conducting more slowly than the pacemaker because the pacemaker is really driving the rhythm. Now you can measure the pacemaker rate, and you should find it to be very constant. And here we have 300, 150, 175, a little less than that, probably 70 beats per minute. Generally, pacemakers are programmed on the 5s, 55, 60, 70, 75, 80, thereabouts. So, but at least from one beat to the next, the ventricular pacemaker should be very regular. I mentioned that there are pacemakers that have atrial leads, and here's an example of an atrial pacemaker. This time you can see a spike. It's very prominent. It looks like a very, very narrow signal in front of every heartbeat, but you can see that the pacemaker spike is followed by a P wave. And then there's a bit of a first-degree AV block, but the QRS complex does not have pacemaker spikes in front of it. The QRS complex is coming from the Purkinje system, and there does happen to be a right bundle branch block pattern here, and this patient also has a right axis deviation. But the point is the pacemaker is functioning in the atrium, and it's making up for someone who perhaps had sinus node dysfunction and had sinus bradycardia. Atrial pacemakers can restore normal atrial rhythm, and they don't necessarily need to pace the ventricle if AV conduction is intact. So you recognize this as an atrial paced rhythm, and then just mention the QRS abnormalities that we talked about, just like you would be reading a cardiogram that didn't have pacemaker activity in it. And the last example here has both atrial and ventricular pacing spikes. So this is an AV paced rhythm, or atrioventricular paced, or AV sequential pacing. There are a number of different names for it, but notice that the atrial spike is followed by a P wave, and the ventricular spike is followed by a QRS complex that looks pretty typical, wide, left bundle branch block looking, discordant T-wave abnormalities, and so forth. So now when you see this on an electrocardiogram, at least you know to recognize this as a paced rhythm. And if you'd like to learn about troubleshooting pacemaker rhythms, then take a look at some of the topics in the advanced course here at the Ecg Academy. In the meanwhile, this is Dr. Nick. Thanks for watching.